especially in ICU scenarios, we as anesthetists always use some form of relaxant to intubate the patients. But in ICU also, I feel as there is an advent of Sugamadex, I think even sir, especially you should promote using intubations with either relaxants or with fentanyl and everything. Okay, because many a times we feel ki, especially in ICU setups, maybe not in big corporate hospitals, but in small ICU setups, maybe there is a little hesitancy in using muscle relaxant for intubating the patient. And then what happens when you're intubating a awake patient, when the cords are adducting, then the intubation becomes difficult, and then once it becomes difficult and it becomes messy, then it really becomes difficult to secure a airway. And plus, we all should always have a hands-on training for all the new PGs as well as new RMOs and everybody for at least using LMAs, so that they can just insert the LMA and at least whenever there is any anticipated difficulty in oxygenating the patient, they can just insert a LMA and ventilate the patient till some help arrives. So that will at least buy some time for them. Okay, thank you.
Thank you, Dr. Archana. It was an excellent lecture. What I would emphasize, one important point is for all those who are new or who joined as a resident, maybe
ठीक है, मैं आता frame change करता है.
A junior person or person, I would definitely suggest whenever you are relatively free. Nowadays, critical care or any specialty area is really very busy. But whenever you get a time in between or when you have good enough strength, always try to go to OR in operating room and see kind of devices they are using, the anesthesiologists are using, maybe a supraglottic airways, maybe have some hands-on. Try doing intubation in simple cases. So this will definitely help you in case of critical scenario, in case of can't ventilate, can't intubate scenario. So one has to be very well versed with at least bag and mask as well as using a supraglottic airway device, because this will definitely help you all to buy the time till the expertise come and take over that particular situation. Thank you, Dr. Archana, once again. It was an excellent lecture.
Thank you, ma'am. I would like to call upon Dr. Smriti Tiwari to please felicitate Dr. Archana, ma'am. I would like to request Dr. Smriti Tiwari to please felicitate our chairperson, Dr. Manish Kela and Dr. Madhuri ma'am. Moving on to our next topic, I would like to invite Chairperson Dr. Vineet Srivastava, HOD in Emergency Department at Terna Speciality Hospital, and Dr. Anita Jain, Intensivist at Terna Speciality Hospital. Moving on to the next topic, the role of ultrasound in assessing and managing the airway, I would like to invite our next speaker, Dr. Smriti Tiwari, MD in Anesthesia, Critical Care Specialist, currently as an Associate Professor at Terna Medical College and Consultant in Critical Care at Terna Speciality Hospital. Today she will share her knowledge how ultrasound is now emerging as a powerful real-time tool in both assessment and management of the airway.
ये भी डाल सकता है क्लोज अप में.
So I think everybody has dealt with the airways and instruments and anatomy. So now I want to stress upon the role of ultrasound in assessing and management of airway.
तुझी फ्रेम हलू
Now, ultrasound guided airway management represents a revolutionary advancement in emergency and critical care medicine, providing real-time visualization of anatomical structures previously accessible only through palpation or invasive procedures. So, what is the point of learning today? So, you should master the sonography.
If your presentation is not.
याची बॅग आहे.
Sorry, my presentation was not coming. Now, can everyone see this? So, role of ultrasound in assessing and managing airways. So, what is important is ultrasound guided airway management. It represents a revolutionary advancement in emergency and critical care medicine, providing a real-time visualization of anatomical structures.
सांग ना मग तिथं तू
Previously
तिथं बसलाय ना.
accessible only through palpation or invasive procedure. So, in OT also we directly palpate a structure or invasive procedure for cricothyrotomy. So now ultrasound has made a revolutionary advancement in emergency and critical care medicine. So I will tell you how it is helping. So what we will learn today is master the sonographic identification of key airway structures including thyroid cartilage, cricoid ring and surrounding tissues for precise anatomical orientation. So airway anatomy using ultrasound. Then identified the cricothyroid membrane. So everybody is in our previous two talks also we had stressed about the cricothyroid membrane insertion of airway when it is a difficult airway. You will see how in the trauma patients, in the large mass in the neck, how we will have, it's very difficult to have a cricothyroid membrane. We cannot assess by palpation. So we can identify the cricothyroid membrane by using a ultrasonography and that will help you to take a insertion of that membrane. Okay. So there are two methods here in which we have to assess the cricothyroid membrane. That is a string of pearls method. It will learn the systemic longitudinal scanning technique that reveals the cartilaginous structures as hyperechoic pearls connected along the airway. And the other method is a transverse method. That is a thyroid air cricoid air method. It is a transverse scanning of the approach of rapid reliable cricothyroid membrane. So how you will go for sonographic airway anatomy? So in the hyperechoic structures, so how it will be seen on the ultrasonography? So it is a cartilaginous elements. It will appear bright hyperechoic lines with posterior acoustic shadowing, creating a string of pearl, and the air tissue will be seen as a reverberation artifact. Okay, and the soft tissue and the carotid and carotid artery and the IGV we can see the anatomic morning we have learned about the hyoid bone, the thyroid cartilage, the cricoid cartilage and the tracheal cartilage. So this is a transverse view of a sonographic airway anatomy. This is seen from the suprasternal approach. So we can see direct visualization of the airway through the ultrasonography. In the center, the torch-like structure is the tracheal ring, the thymus gland, which can see I have made it in the color so that it is easy to identify, and the carotid artery and the IJV, which is seen as a blue structure. So this is so transverse section to the tracheal cartilage. You can see the tracheal ring as a white cartilaginous structure. You can see I have pointed the marker and the comet-shaped air interface. Okay. So now I will show the steps how to identify the tracheal ring and the cricoid cartilage. So thyroid cartilage, it will appear as a hyperechoic arch-shaped structure with characteristic V configuration. So tracheal thyroid cartilage will be having a V configuration. I will see in the other slide also. Then air column will be seen in the cricothyroid membrane. It is a bright hyperechoic line representing the air tissue interface within the larynx. Then the cricoid ring will be seen as a complete hyperechoic ring structure visible as a continuous circle in the transverse plane. Okay. then the tracheal air will be seen as a hyperechoic black structure. Okay. So this is a TACA method, that is a tracheal airline, cricoid airline sequence. So this is how we will be seeing. So we will keep the probe and we will see the all four structures. So generally when we go for a sonography, it is very difficult to recognize. But I have sort of made it easy to see for the TACA method. So what are the steps? See how you have to keep the probe. This is transverse at the level of thyroid cartilage. You will see a triangular structure. Can everyone see this triangular structure? So I have made it easy by giving the anatomy also. So we can see the vocal cord, the arytenoid cartilage, the vocalis muscle, and this is the triangular structure. So if you are keeping the probe as transverse in the thyroid cartilage, you can see this is also known as the focus of the airway. Okay. So focus of the airway at the level of thyroid cartilage, you see a triangular structure. Then when we go it downwards, so this is the cricothyroid membrane. So you can see the at the center of the probe, you can see the reverberation of the air lines. So this is a cricothyroid membrane. Okay. Then at the level of cricoid cartilage, you can see the semicircular structure with a C cartilage. So this is a cricoid at the level of cricoid cartilage. Then what we will do? Take the probe upwards. That is step 4. Again you can see the reverberation. So now we have confirmed that this is a cricothyroid membrane. Okay, so I have made it easy with the ultrasound that we have. So now we can do a direct visualization of the cricothyroid membrane and take the prick for cricothyrotomy. Okay. So other is the longitudinal approach. So longitudinal approach reveals the cartilaginous structures as hyperechoic pearls. I have made it colorful here. You can see the colorful structures connected along the midline with the cricothyroid membrane, appearing as a hyperechoic space between the thyroid and the cricoid cartilage. So position of the probe longitudinally over the midline, identify the thyroid cartilage, locate the cricoid cartilage and target the hypoechoic between the structures. So this is how it is seen. So we have kept the longitudinal probe here and you can see the string of pearls here and the cricoid cartilage which I have marked by red. So this is a longitudinal approach, and this will also be helpful in the vertebral tracheostomy when we are doing in the tracheal cartilage. Then step 6 is you have to keep the probe at the level of thyroid cartilage, longitudinal approach. You can see the cricothyroid membrane. So now it has made us easy to visualize the cricothyroid membrane by keeping the thyroid probe. So when someone is doing even I will tell you how, if the intubation has been done, so how we will confirm it on the ultrasonography. So one person can keep a probe on the ultrasonography while someone is intubating the patient. So what is the clinical application? Place the high frequency linear probe. So which probe we have to use? High frequency, the thin probe which is there. High frequency linear probe perpendicular to the skin over the anterior neck, starting at the thyroid prominence and scanning caudally. Identify the landmark, which is the arch-shaped thyroid cartilage and the cricoid ring. Measure the depth. So this is helpful for measurement of the difficult airway also. Measure the distance from the skin surface to cricothyroid membrane to determine the appropriate needle length for the percutaneous axis. So what is the ultrasound guided procedure planning? So ultrasound evaluation enables the comprehensive pre-procedure planning, identifying the anatomical variations, measuring the tissue thickness, and marking the optimal entry points before emergency situation arise. Skin to membrane distance measurement, identifying of vascular structure. So it will also help to prevent any needle insertion into the artery or vein and any vascular complications. Assessment of tissue layers, documentation of anatomical variants. So pre-marking the cricothyroid membrane location in high-risk patients can significantly reduce the procedure time during emergency situations. So I have shown this picture. So when we are very confident that we are doing a cricothyroid membrane, but see in this situation when there is a trauma patient or there is a mass in the neck, so it will be very difficult to put a palpation method. So ultrasonography will help you to recognize the cricothyroid membrane. Okay. So role of upper airway ultrasound is very important in having the applied sonoanatomy of the upper airway, sizing of the tube, then airway device placement. I will also show you how we will see the ultrasonography in intubations. Then use of upper airway ultrasound for percutaneous trachothyroidotomy and this percutaneous tracheostomy. Then evaluation of the epiglottis, the upper airway ultrasound educational learning curve is there. Okay, so this is the evidence-based medicine in which 2016 they have advised to use the ultrasound. So this is the focus of an endotracheal tube placement through ultrasonography. So I had shown you that suprasternal approach in which can see the tracheal ring. So this is we can confirm endotracheal tube placement by doing the ultrasound in the suprasternal approach. So I will show you how we are seeing. So direct ultrasound guided endotracheal tube placement. You can see that the tube is going in the cricothyroid membrane, that is in tube. So this is a double track sign. So when someone is doing the intubation, can keep a probe here and can see whether the tube is going in the esophagus or it is going in the trachea. So direct confirmation by doing the ultrasound can rule out the esophageal intubation and prevent complications. Okay. So what is the tube? Where should we place the scope of ultrasound? Is the suprasternal notch is the most common cause. It is causing 100% confirmation of the tube. Okay. So what is a real-time procedural guidance? So even before the percutaneous tracheostomy, which we are doing in the ICUs, initial positioning is establish the optimal probe position and membrane visualization before needle insertion, ensuring clear sonographic landmarks. Needle visualization through tissue layers also helps to prevent the vascular complication. Membrane puncture will be helpful seeing the ultrasonograph, and the tube placement. Verification of the proper tube positioning with the tracheal lumen using ultrasound visualization is of the bilateral lung sliding. So what are the clinical benefits and future directions? 95% success rate using the ultrasound guidance, 40% reduction in complications by pre-marking the, so it should be widely used in the emergency medicine and the critical care, and complications are the lower incidence of vascular injury and misplacement of the ultrasound. So what are the emergency applications are pediatric airway assessment, obese patient, as we had seen in the morning, the RAM position and the obese patient. So identifying the tube, difficult airway assessment is also important. So point of care should be widely used. So this is a chart which I have placed. The values will be seen from the net, I think. So everybody is having approach to net. So I have just seen, I have placed a table to see that the difficult airway prediction using ultrasound. So we have to see the distance from skin to hyoid bone, then skin to epiglottis is the most common used. Distance from skin to epiglottis in the midline sagittal scale correlates with the Cormack-Lehane grade. So before doing an intubation, we can plan for whether this can go difficult by seeing the ultrasonography. We should make a habit of doing this, so to rule out the difficult intubation. So we will be prepared for as a difficult airway card. So tongue thickness, then pre-epiglottis space, this can all have a sensitivity of 70 to 75% in predicting a difficult airway. So do you want a revision? See. 4 steps. Thyroid cartilage, there is a triangular structure. Then the air identification airline. Then the circular structure which is showing the C cartilage, okay, and the airline. Was I too fast to do my presentation or any problem? Okay. So I have just added to your knowledge of airway. Thank you. I just don't want to take too much of slides for a presentation, but this was my talk for today.
I just want to add one thing, that for sonography, people who are working in critical care, they have access to the sonography machine. So first try to find out the anatomy of the patient. And now every critical care department has sonography machine. So even the normal patient take the consent and perform the airway sonography, so that you will find out what is the normal anatomy. So in difficult situations, mostly this is done during difficult situations to reduce the time for intubation or surgical airway management. So during that time, you will have access, okay, this is a normal thing and now you are intubating or doing surgical thyrotomy or whatever procedure you are performing. Then only you will have access. So even practice makes it perfect. Don't think that with first attempt you will going to get it.
Thank you, Dr. Smriti. Dr. Archana, I would like to invite you to please felicitate Dr. Smriti Tiwari.
Hello. Okay. We are very privileged and honored to invite our next speaker, Dr. Amla Kudalkar Madam. She has been my teacher. As at present, she is working as Professor and Head, Department of Anesthesia at AIM Hospital, Mumbai. Welcome.
A very good morning to all of you, and little offbeat beginning of the lecture. Let me begin with the case. An elderly male patient was rushed inside ICU. Obviously in respiratory distress, he saw movement of the diaphragm, accompanied by an intern and relatives, but without any papers. Now, whatever he had in hand was ABG chit, which showed PO2 less than the PCO2. Upon inquiry, it was found that patient was a known case of COPD. He was operated for total gastrectomy under GA with thoracic epidural. 2 days later, the patient developed severe respiratory distress, and here he comes to the ICU. He was rushed to ICU without any prior intimation, and this is most of the time is the scene, at least in our hospital. And who is there to receive? A tiny JR2 or JR3, you know. So whatever he could do, he tried doing. He decided to intubate seeing the respiratory distress. So he gave 50 micrograms of fentanyl. Now this for intubation, it happens to be Ayurvedic dose, isn't it? So he intubated intubation with Macintosh blade. Patient struggling and restrained, intubation not possible. So he decided to give propofol. Now the starting BP was 140, 150 systolic, but as soon as he gave propofol, somebody mentioned propofol, BP dropped to 66 millimeters of mercury. So now two problems, respiratory distress and hypotension. Then he gave ephedrine. Intubation tried again, cords not visible, asked for McCoy blade. With McCoy he could barely see, Cormac-Leon grade was 3B. Now we tried with bougie, not knowing that for 3B you are not supposed to use bougie. Everything led to dental trauma, bleeding. This is the time when video laryngoscope was asked for. Now video laryngoscope was secured inside the sister's locker. That also you can imagine. It was never outside. Meanwhile, senior call was sent. Intubation attempted with VLS but could not because poor vision due to secretions and blood. So this is the scenario development. Intubation tried again with McCoy, and somehow the SR was able to pass in the tube. The air entry was doubtful, the ventilation continued, but the saturation continued to drop, led to bradyarrhythmias. Now this was a perfect example of Murphy's law, that if anything can go wrong, it will, and it really did. So this, we don't want to enter into such situation. So what should we do? And this is exactly topic of today, that is how managing airway in ICU is different from OR. And what are the strategies to improve successful airway management? And this is a place where I work, KEM Hospital, and Sandeep and Manish Kelas were also the alumni of our institute. Thank you for having me here. Now this is the fourth national audit project, NAP4, which was the main person in this was Tim Cook. It dealt with major complication of airway management in the United Kingdom, which showed that nearly 25% of the major airway events were from ICU and emergency department. So 1 out of every 4 patients belonged to ED and ICU, and they were more likely to lead to permanent harm or death. And the gap analysis of this project showed that it were mainly the human factors which were at work. So we need to train ourselves. And what were they? Poor identification of at-risk patient, lack of situational awareness, fixation biases. You need to intubate this patient. Maybe you can try with supraglottic airway device. Nobody thinks of that. Delayed recognition of the events, lack of proper plan, lack of skilled staff and equipment, failure to intubate critically ill patients, and failure of rescue techniques. Another thing is unrecognized esophageal intubation, which happened in our case, the one which I narrated. Why? Because capnography was not used. Failure to interpret capnography, displacement of the tracheal tube, especially when you send the patient, transfer the patient for CT, MRI, etc. And delay in recognition of this displacement. These are the various causes of problem in ICU. And definitely there are two entities, OR and ICU. So in case of OT, it is an elective intubation done in a stable, optimized patient with good physiological reserve by a skilled anesthesiologist. Whereas in the ICU, it may not be the situation, though we want to approach there. Intubation attempts under duress, there is a time constraint, and the incidence of complication is very high. So let's see what are the differences. Usually ICU patients are critically ill, they are hypoxic, they are hemodynamically unstable, they are acidotic. So this is called as physiologically difficult airway. There are two varieties, anatomically difficult airway and physiologically difficult airway. So because the anatomy may be normal, but because the physiology is such, like you can see in this, and these are the typical ICU patients. I mean, all these are KM and Sion hospital excess, so you can connect with this. Pleural effusion, ARDS, pulmonary edema. So all these patients with so much lung discharge, how much reserve they must be having, for safe apnea time. So this is actually matters. Check this patient. There is another patient. I am unable to show it, but that patient had severe pulmonary hypertension with PASP 124. So such patients, it is really difficult. They do not give you even a few seconds to intubate. So let's see the difference. Patients are not fasted. Even if they are fasted, you should not take them so. Because of the stress and because of the medication, there is always gastric stasis. Airway is not evaluated prior. Airway anatomy may be distorted because of edema, trauma, cervical collar, etc. Limitation on the use of the pharmacological agents. Dealing with extreme agitation, shock, bronchospasm. Limited space and limited access. You can imagine on one side there is a ventilator, another side suction machine, monitor on the top of your head which you cannot see. So all these, so everything is not optimally positioned. And awakening the patient is not possible because you are going to intubate as an emergency and then there is no turning back. You have to go ahead. Somehow you have to put the tube inside. And lack of experience and training of assistants. Now most of the ICUs, I am told, they are manned by, it may not be allopathic doctors or, usually juniors are there placed. The consultant is available on the phone. So it is little suboptimal for the even all this imposes lot of cognitive overload and impairs the decision making and performance of the poor guy who is sitting there. So intubation without planning can lead to utter chaos, confusion, and what you require is systematic approach, algorithms, cognitive aids, and preparedness. General preparedness is required. So first is you have to see, does it actually need intubation or no? So that you find out. Or something else, like just opening the airway, or putting an inserting an airway, or just giving oxygen by mask will help. Suppose you feel that airway, yes, intubation is required, then assess the airway. I believe that there was a separate lecture on that, but I want you to know these three things. It is not general assessment of the airway. First is see whether the airway is going to be difficult or no. Second, you see whether the physiology is stable or unstable. And third is what is the aspiration risk. So assessment of airway includes all these three things. So quick history and examination, I won't go in detail, but see other things. Check history with surgical residents and relatives. Presence of illness, comorbidities, medications, any surgeries, any history of difficult intubation. Because difficult intubation in past usually means difficult intubation even now. Fasting status, any contraindications to succinylcholine. All this you should see. And there is any important thing is check for any existing IV line. Even if you see one, don't believe it. Make sure that it is patent, put some glucose in there, and then you can, otherwise take fresh IV. And then quick USG of airway, focus as she said. For airway, lung condition and IVC collapsibility. It is a collapsing IVC, you don't know, you cannot push in propofol, the way it happened, So all these things are also equally important. And this is what Madam has said, so I won't repeat again. It is always better to go for CTM, cricothyroid membrane, and mark it with pain. I am sure because of the movement of the neck, the exact position may not be there, but it is at least make it a point to look for CTM in all cases. All this, one look at this case and you know that they are red flag signs for intubation. So you will be careful. But somebody apparently is looking normal, may not be normal in these cases. Here, airway examination, Malampatti 3-4. Our patient is going to be supine. It is not going to be an ideal situation. But Malampatti examination in supine position works equally well as in sitting position. So go for it. It has lot of importance. And rather than going for one factor, always go for these indices, because the sensitivity and specificity of individual factor may not be great. But when they are combined together, then they offer more sensitivity and more specificity. So more chances then you can pick up all these difficulties. So it can be with face mask ventilation, or it can be with supraglottic device insertion, or it can be simply intubation. So remember all these indices, and all these are available on internet. So whenever you are assessing, you can actually refer to it. What works well and what has validated in case of ICU is Makocha score. It is a mnemonic which includes 3 domains and 7 factors. If you see till now, most of the indices, they were referring to only the anatomical structures. But this is the only score which takes into consideration all 3 aspects. So factors related to patient is Malampatti score 3 and 4, and as I said, it carries lot of weightage, 5 points. Then presence of OSA 2, and then reduced mobility of the cervical spine and limited mouth opening, 1 each. Factors related to pathology will be coma and severe hypoxia. Remember those X-rays. And factors related to operator, non-anesthesiologist. So it is a risk factor. So kudos to anesthetists, okay? So whenever score is 3 or more, anticipate difficult intubation. So what will survive is being protocolized and prepared. You have to be prepared. Consider every intubation as potentially difficult intubation. You should have a receiving area for receiving the patient which has crash cart, difficult airway cart, where ventilators, ambu bag, not to forget that, and oxygen source, and tray of syringes filled with emergency drugs available. Not only emergency, but drugs required for quick intubation. And this is the airway card. You see according to availability of equipment what you want to put in each, but it should be there. You should know it, and it should be there, and it should be well labeled. Face mask, the equipment for intubation. If that fails, then HGD, etc. And all the syringes. And this is the Alfred ICU intubation checklist. So meticulously, I'm sure 2-3 people at least are there in ICU. So 2-3 people, they go through this checklist so that not a single point is missed out. Failure to plan for the failure is a major cause of airway catastrophe. So you have planned A, but suppose this doesn't go, then you should have plan B and plan C also with you. Now there is, I'm sure your ICU must be having them. These are intubation bundles or CVP bundles. All these are usually in place for ICU. So what is a bundle? It's a small straightforward set of evidence-based practices which when performed collectively improve the patient outcome. And as you can see here, this is control. So without any bundle, so haywire, whatever you feel HGD, one feels ketamine, one feels propofol, it is as per that. So they have much more complications than the one where the bundles are in place. The complication rate is much reduced. For example, just presence of 2 operators, fluid overload. So whenever you want to intubate, you can give fluid properly so that patient doesn't collapse at the crucial moment. So these are the various bundles. You can prepare your own bundle as per your patient load that you are having. In 2016, AIRWAY came out with beautiful guidelines. I mean, all of you must know that. Before that, even DAS guidelines were there. Now we were witness to these guidelines. Even this Udaipur conference, these guidelines are going to be there. They are revised. So go through these guidelines, and the beauty of AIRWAY guidelines is they offer much safety to the patient rather than DAS. DAS is UK based. And this is, I will just run through that so you know. Pre-oxygenation and induction of anesthesia. If face mask ventilation is unsuccessful, what to do? If it is successful, what to do? And then in case of failed intubation, what you should do? HGD, rescue face mask ventilation, and emergency hypothyroidectomy. Now we will come to each point, one after the other. We should have presence of at least 2 operators. One is supposedly, so one little senior, one expert in airway management. Check for patency of IV line, new IV cannulation if you are not sure. IV bolus of 500 ml of crystalloid and or 250 ml of colloids, suppose status you want to give, provided there is no cardiogenic edema. Vasopressors are kept ready in case the BP crashes, so noradrenaline mounted and attached. Even we prefer, if the starting BP is around 80-90, we do start noradrenaline prior to going ahead with intubation. Good working suction at hand, oxygen source equipment, ventilators, and induction agent muscle relaxant drawn and ready. The position for intubation, I was not there for this lecture, but I think this was probably discussed. That is, it is a ramped position where the rest of the torso is at a higher level, And this is same as the head elevated laryngoscopy position, HELP. So it is 25 to 30 degree head high. It improves the upper airway patency, it improves the FRC. And this position is given so that the external auditory meatus is at the level of the sternal notch. In case of cervical spine injury, you cannot give this position. So what you should do is manual stabilization of the neck. Pre-oxygenation in hypoxic patient in ICU. The usual pre-oxygenation for 3 minutes may not suffice. If you remember those X-rays with the destroyed lung, even 5 minutes will not suffice. So what is required is oxygen under pressure. So with tight fitting mask, high flow of oxygen of at least 15 liters per minute, so as to have ETO2 of more than 90% in ICU patient. Again, this may not be available because this is usually available in the OR where there is a respiratory gas monitor. In our regular monitor, it may not be always available. You give either CPAP through mask, use HFNC, that is high flow nasal cannulation, or you can use NIV with pressure support. Actually ventilate through that. This unloads, this sort of causes recruitment of the alveoli and it unloads the respiratory muscles. It prevents absorption atelectasis also. So you have a patient who is now little well aerated. Even 10 minutes of pre-oxygenation at normal pressure will not help this. So the study says that in patients who received NIV, the incidence of severe hypoxia was 10% as compared to the control group where it was 25%. Then there is something, a terminology as delayed sequence intubation. Remember our patient who was struggling and he had to be restrained and then somebody gave propofol. Now this is a patient who will not do well. In fact, here you should have given ketamine prior. Just calm him down so that there is more acceptance of the oxygen. So this is called as delayed sequence intubation. A small doses of sedative, usually injection ketamine are given prior to pre-oxygenation so that acceptance of oxygen is better. Now what are the different methods of improving oxygenation? Now this is when we are actually intubating. This is called as per-oxygenation. What we discussed earlier was pre-oxygenation, so prior to intubation. But this is per-oxygenation, that is when you are actually in the process of intubating. Now when you are pre-oxygenating, you are ventilating. And what happens when you want to actually intubate? You keep the mask away, you do laryngoscopy, you may not see the larynx at first, and all this is the apneic period, hypoxic period, which is not tolerated well by these ICU patients. So you should continue to give oxygen even during this period, and that is called as Nodisat technique, nasal oxygenation during effort securing a tube. So always give nasal oxygen by prompt or cannula at very high rate, 10 to 15 liters. Or if you have Thrive, well and good, that is transnasal humidified rapid insufflation, which we can give oxygenation at high flow rate and at slight pressure. It has slight CPAP-like effect also. So this is oxygen by mask, and this is the nasal cannula of HFNC. This is C. The patient is being intubated, but at the same time oxygen is going at 60 liters per minute, and that too humidified. So it definitely carries weight. There is always a chance of aspiration. So how to reduce this risk of aspiration? Discontinue enteral feeding. Suppose on round you feel that you want to intubate a certain patient, tell nurse that don't give the next feed. Sucking out the remaining gastric contents by nasogastric tube and leave the nasogastric tube in place and keep it open. Don't close it. If you close it, then it will come by the side of the endotracheal tube, by the side of the rise tube. So keep the rise tube in place, but leave it open and attach a back to it. And gastric focus, now ultrasound is there in each walk of life, so to know the residual volume of the stomach. Laryngeal handshake to know the position of the cricoid, because that is where you want to press. And application of cricoid pressure by a trained assistant. Mind you, if the cricoid pressure is not given well, it can cause more harm than any good. And force should be reduced or removed if there is difficulty in mask ventilation or intubation. Now this is how you do. You can actually locate the cricoid cartilage by using focus also, but it is usually very well seen. Laryngeal handshake. Then keep your fingers there. With the other hand, just support the cervical spine so that pressure is well applied. And initially it is just 10 newtons or 1 kg, but as the patient loses consciousness, you can apply more pressure, almost 3 kg. Anesthesia induction, it depends on hemodynamic stability and state of consciousness. Usually midazolam and fentanyl when given, they reduce the requirement for anesthetic agents, so one should give them. The drugs of choice for induction is Here it is not propofol. Propofol causes, especially in hypovolemic, hypotensive patient, it further reduces the pressure. So the drug of choice in ICU setting is ketamine or etomidate for the hemodynamic stability that it provides. This part is already discussed. Should muscle relaxant be used or no? If you do not use muscle relaxant, the induction, the drug that you need to give is much higher, So it is always better to use muscle relaxant. Now there is choice whether you should give spolin, depolarizing or non-depolarizing. Non-depolarizing muscle relaxant, they take a long time except procuronium, and for onset as well as offset. You give vecuronium and then you give other drug and then you cannot intubate, then you are in soup. So spolin was always preferred. However, it has its own complications, like it causes muscle fasciculations, increases oxygen requirement, produces hypercapnia, increases intracranial pressure. So initially only I had mentioned in slide that look for any contraindications for spolin. If it is neurologically deficit patient, you are not going to give spolin. Now even this is available, rocuronium, which will give equally good intubating conditions if you give in sufficiently high doses of 1.2 milligram per kg. And with Sugamadex by your side, you are feeling safe to use it also. So if you give rocuronium but you cannot intubate, you can always reverse by giving very high dose, 16 milligram per kg of Sugamadex. Always the choice would be modified RSI. So graded doses. A typical RSII that is not modified requires a induction dose, pre-calculated induction dose to be given fast, followed by muscle relaxant, cricoid pressure and not ventilation. But here you have to check between the not ventilating the patient during apneic period may cause severe desaturation. Plus rapid administration of any drug will cause hemodynamic instability. So you do modified RSI. So graded doses, not a fixed dose, cricoid pressure and gentle IVPV not to exceed 20 centimeters of water. And this is what they have seen, that when you actually mask ventilate during tracheal intubation, the complications are less. This was a study, Prevent, which was published. So patient receiving ventilation had significantly higher saturation and lower incidence of hypoxemia, and the aspiration risk is not high. So continue gentle ventilation, you can call it as gentilation, if hypoxia is imminent. And there may be plethora of devices available. Choose your primary device, whatever you are comfortable with. So you want to have timely or traumatic intubation. What I would prefer is always video laryngoscopy should be your primary device, and which has been reiterated in various studies also, because it improves the Cormack-Lehman grade and the movement of the neck is not required, and it is possible to watch live, real time by your seniors also. One flop side of this is, even if you see the larynx, you may not be able to maneuver the tube inside, because larynx is seen because the chip is at the tip of the larynx, the laryngoscope. So you will keep the larynx, but larynx is so anteriorly placed that without that it is so tempting to put the tube, but it won't go. So you have to use a hyperacute stellate, hockey stick stellate with it. So multiple are available. Be comfortable with one or two and stick to them. And it has been seen that even if predicted difficult, there was no incidence of difficult intubation with VLS. So a laryngoscope should be available, video laryngoscope should be available and should be considered as a first option, especially when the Makocha score is more than 3. Confirmation. NAC4 project said that the problem was because the tube was not confirmed by ETCO2. What we usually do is stethoscope, but that is not good, because the patient may be struggling, there may be bronchospasm, the chest wall may be thick. So you should go for capnography. I would give more importance to capnography than pulse oximetry. So that is something you should give, and after intubation you are confirmed, you shall give recruitment maneuvers. So little speed so that the airway alveoli remain open. I will run through this. This is equally important to use because this is you can actually see the where your tube lies real time. This is if it is normally placed endotracheal tube, it is here and the esophagus is collapsed nearby. But if it is, you can see double tracheal talum. This is the trachea which will remain open anyway, and this is the esophagus which is now open because of presence of the tube which is wrongly placed. So double tracheal shadow on airway focuses in the person. So this is how we go. And this is rescue face mask ventilation followed by FONA. I am sure most of you will be, you are proficient in doing FONA, that is surgical or needle cricothyroidectomy. Vortex approach, sometimes they say that rather than doing the one thing, take 3 attempts at intubation, 3 attempts at HGD. There are 3 things you can do. You can intubate, you can put HGD, or you can face mask ventilate. Do one after the other, one attempt. This may not. So don't go through hierarchy of 3 attempts. 1. If it doesn't get, another round of 1. This is how some people say. Checking for leak is equally important. You can make out from the flow volume loop. Okay. Because if you do not inflate the cuff properly and do not check for leak, then your tidal volume is going to go wasted. Not only that, it can cause aspiration also. So this is either change in the set tidal volume and exit tidal volume, or you can see on the flow volume loops. Lignocaine with soda bicarb in the endotracheal tube, always acceptance of the endotracheal tube is better. Secure the tube well, either using elastoplast or there are commercially available tubes also. Post intubation X-ray test must. First you can do focus followed by X-ray. So the tip of the tube should lie above the carina, at least 2 finger breadths. If you do not, then the left side lung will not get aerated. Aspiration is it is a reality. I mean, that's why you should inflate the cuff well. And whenever you are nursing, all patients should be in head-eye position, 30 to 45 degree head-eye position in ICU. Check for leak, dislodgement of endotracheal tube, and if you are planning extubation, do not give feed prior. Avoid drag on the tube. The entire big circuit, pressing, pulling the endotracheal tube. So that you should not do, and be negative pressure alarm on a ventilator or ETCOT is very important, that you come to know that there has been disconnection. Obstruction you should check for, so good dedicated nebulization. The HME filter you should change every day or depending upon the patient's secretions, because clogging can not only increase the airway pressures but it will be ineffective in the ventilation also. So extubation also can, since it is airway management, I thought not only intubation but extubation is also I will consider. So accidental or self-extubation can occur. If you do not extubate the patient on time, the patient will do it for you. So be vigilant when to extubate this patient. It should be timely this thing. This is the misplaced tracheostomy causing surgical emphysema. How to identify accidental extubation? Absence of capnograph. So all, at least in KEM ICU, majority where the patients are ventilated, all monitors have capnography. Patient may not have pulse oximetry, but capnography is must. And if it is accidental extubation does occur, then you may consider giving the extubation trial to the patient, and then have close vigilance. If the patient becomes hypoxic, again re-intubate the patient. Extubating the trachea is challenging in case of difficult airway. I mean, like Rice tube, you cannot remove it. You have to give it a try. And if you feel that the intubation was difficult to start with, extubation is also going to be difficult. So you should have another backup plans. So first is check whether the airway is idiomatous. And how do we check that? Either we do the airway, you can do ultrasound and you can actually see the thickness, but for that you should see the prior, you should have the prior measurement. But easy is to cuff lick test, which we do anyway. So deflate the cuff and see whether there is any discrepancy between the set volume and the exhale tidal volume. If it is more than 100 or so, that means it is normal. So a positive cuff lick is good. If there is no discrepancy between the two, that means there is airway edema and airway is clasping the your endotracheal tube. So it is not good. So that means after extubation, the airway is going to collapse further. So then stage extubation, either you put in HGD behind the supraglottic HGD behind the tube, that is called as Bailey's maneuver. Insert the HGD and remove the tube. So you have something there, the airway continuum is maintained. It is not like remove this and then you again panic and put in another, nothing like that. So put in HGD behind, remove the tube from front. So tube, your HGD is already in place. Attach again ETCO2. All this should be done. And if you feel that even this may not suffice, then what you should put is, you put airway exchange catheter, madam has already said about it. So you insert it through the endotracheal tube, remove the tube, make sure that if it is oral intubation, put in airway. Otherwise the patient bites on the airway exchange catheter, one remains inside and the other comes on the floor. So always airway with airway exchange catheter. So the way ahead is, you are a part of this. You should have widespread use of advanced airway gadgets. You should be exposed to this. So attend various workshops, regular training, simulation skills, forming algorithms for your own ICU. You may not have all equipment. Whatever suits your patient load and whatever you have in hand, you have to form algorithms for them. So just quick recap, ICU intubation differs from OR intubation that we have accepted. You should have protocols, checklists and bundles in place. You have to be 24/7 preparedness. Quick assessment of the airway, use Mako chart. Positioning and pre and per oxygenation, modified RSII. Use video laryngoscopy as your primary, not after the first intubation phase, attempt phase. Confirmation of tube placement by capnography. And always use recruitment maneuver post intubation and support the hemodynamics throughout. Thank you so much. Thank you for having me here.
पीछे आना जिधर झाड़ रखा है हाँ उधर आना
Thank you, ma'am, for such a wonderful and informative session. Any question? Okay. I would like to invite Dr. Sandeep Agarwal sir to please felicitate Dr. Amla ma'am. I would like to request Dr. Madhuri ma'am to please felicitate our chairperson, Dr. Vineet Srivastava and Dr. Anita Jain. Dr. Madhuri ma'am. Requesting Madhuri ma'am to please felicitate Dr. Anita ma'am. Moving on to our next topic, I would first like to invite Chairperson Dr. Ajay Kukreja sir, Consultant and Physician, Dr. Resham Kukreja ma'am, Consultant and Physician, next topic for the event, Mastering the Art of NIV and HFNC. NIV and HFNC have become game challengers in managing airway failure, respiratory failure, and can significantly reduce the need for invasive ventilation and improve the patient outcomes. For this session, I would like to invite Dr. Sonali Wadi, physician and intensivist at Wadia Hospital. Dr. Sonali Wadi.
So the success of non-invasive respiratory therapies, it lies in the early deployment for managing respiratory failure. I'll be discussing on the basics of non-invasive respiratory therapies, NIV and high flow oxygen therapy deployment for optimal patient care. Good morning, namaste, and thank you. Thank you to Dr. Sandeep and thank you Dr. Nikhil. My talk would be divided into these subheadings, and the non-invasive respiratory support that I'll be discussing on will be high flow. Can I have a pointer? Is it possible? Okay. It will be divided into high flow oxygen therapy, that's the nasal and the tracheal, and the non-invasive ventilation, that is continuous positive airway pressure CPAP, and the bi-level positive airway pressure BPAP. The BiPAP, actually these are with the small I and the capital I, these are two trademark modes of BPAP. So the BiPAP, they are the brand names, whereas BPAP is the generic term that is used. Starting off with high flow oxygen therapy, looking at the physiological benefits. So the heated humidification of inhaled gas through HFO3, it helps in the secretion clearance and it reduces the bronchoconstriction. The washing out of the upper airways, it helps reduction in the dead space and it decreases the carbon dioxide levels. The high nasal inspiratory flow, it helps reduction in the nasal resistance. The positive airway pressure that is generated because of the high flow, it helps in recruiting the atelectatic lungs. On an average, 10 liters per minute of flow, it generates about 1 centimeter water of pee. And there is also a decrease in the entrainment of ambient air. So this helps increase the FiO2 supply. So as a result, what happens is that there is the reduction in the minute ventilation, increase in the dynamic compliance, the patient's respiratory rate decreases, the work of breathing decreases, and this finally translates into improved clinical outcomes. Looking at the indications, patients with hypoxic respiratory failure because of any cause would be in consideration for HFOT.
those who require intubation can be used in the peri-intubation period, even for post-extubation respiratory distress. Any patients with do not intubate cold status, you can consider using HFOT. And it can even be used at the time of certain procedures, for example, bronchoalveolar lavage, transesophageal echocardiography. And when would we not use the HFOT? In patients who are not spontaneously breathing, who have nasal fractures, nasal surgeries, fractures at the base of skull, epistaxis, HFOT would be contraindicated. The interface. So there are two interfaces. There is a nasal and the tracheal. Tracheal is wherein the cannula is connected to the patient's tracheostomy tube. And for the cannula size, there are color-coded cannulas for the adults, and we use larger cannula size for hypoxemic patients and smaller ones for the hypocapnic patients. Just a practical tip on the high flow oxygen therapy interface. So in order to maintain an effective flush of the carbon dioxide, we need to be sure that the cannula doesn't occlude more than 50% of the nares. And increasing the flow rate would help increase the airway pressures, and increasing the prong to nasal nares ratio also helps increase the airway pressures. So now, initiating, how do we do that? What are the settings? So we need to dial in 3 settings when placing a patient on HFOT. The FiO2, that is what is the concentration of the oxygen that would be delivered to the patient. Second would be the flow. That means how quickly will this FiO2 will be delivered. The recommended number for adults is at, the starting flow rate is at 20 to 35 liters per minute. And the temperature is the third setting. So it's important to keep in mind that the temperature not be cold, and we don't give dry air, because otherwise this will affect the mucociliary function and the clearance of the secretions. Another practical tip would be to tell the patient to keep the mouth closed when breathing with HFOT. This will help generate higher PEEP versus if they breathe with the mouth open, with a reported difference being 1 to 2 centimeter of water of PEEP. And how do we titrate? So the flow rate is titrated predominantly against the patient's work of breathing. Yeah? So the key principles for titration include prioritizing the flows. Increasing the flow rate helps reduction in the dead space in the airways and thus helps improve the oxygenation. If the oxygenation or the respiratory rate do not improve, then we need to increase the flow rate in increments of 5 to 10 liters per minute. And we should prioritize increasing the flow rates over the FiO2. And in case if the patients do not tolerate NIV, or when the intubation is risky, that's when we consider HFOT. Those are one of the indications where we consider HFOT and increase the flow rate in these patients. Next is monitoring. So we need to monitor the heart rate, the respiratory rate, the saturations, the work of breathing, the level of consciousness. We need to be aware that the power of a single parameter to predict the subsequent need for intubation is low, and hence composite scores have been devised. For example, the ROC score, that is the respiratory rate oxygenation index, and the Hackor scale, that is the heart rate, acidosis, consciousness, oxygenation, and the respiratory rate. So when the ROC score is high, thank you, the patient would be responding. Yes, the patient would be responding. And if the ROC score is low or it's dipping down, that means that the patient is worsening and there is a likelihood need for intubation. And then there is the weaning. So the weaning criteria. So the main thing for weaning would be the reason for which the patient was initially put on the HFOT, it has resolved or it's improving. that there are no signs of respiratory distress, the saturations are good, and the vital signs are stable. And which are the weaning strategies? It would be flow-only weaning. That means you reduce the flow rates first. FiO2 only weaning. Simultaneous weaning, wherein the FiO2 first and followed by the flow rate, or a step-down weaning, meaning once the FiO2 and the flow rate have reached a lower level, that the patient can, and the patient still needs oxygen, switch over to nasal prongs or the Hudson mask, or if the patient doesn't need, just then no oxygen. At the time of weaning, do monitor for respiratory distress and go back to the previous settings in case if there is any evidence of respiratory distress, and then retry later. Right. So switching gears, we'll move on to non-invasive ventilation. Looking at the benefits, NIV, it augments minute ventilation. It unloads the respiratory muscles, so it improves the compliance, decreases the airway resistance. It helps improve the alveolar recruitment and the gas exchange. The positive pressure provided by NIV reduces the preload and the afterload on the heart. And it also helps reduce the imbalance between the diaphragmatic strength and the work of breathing. And the PEEP provided by NIV, it helps keep the airways open during exhalation, meaning it helps maintain the upper airway patency. So what would be the inclusion and the exclusion criteria? So any patient with acute hypercapnic failure because of any cause, acute hypoxemic failure, or even post-extubation would be candidates for NIV. Post-operatively, they can be considered. Those who are in a do not intubate status and are in respiratory distress, just for a little bit of comfort, you can start them on NIV. And NIV can also be used during the procedures. These patients usually display, clinically, they would be moderately to severe dyspneic. They would be tachypneic respiratory rates of 24 or more. Use of accessory respiratory muscles, or they would also be having paradoxical breathing. And the physiological criteria would be, their CO2s would be on the higher side, more than 45. pH would be on the lower side, less than 7.35. And the PF ratios of less than 200. And whom would we not give the NIV? Those who have impaired level of consciousness, who are agitated, confused, not cooperative, plenty of secretions, they have vomiting, hemoptysis, hematemesis, post-cardiac arrest, patients with central apnea, and having facial trauma, surgery or burns are some of the contraindications for NIV. Looking at the interface of NIV, multiple interfaces are available. The masks, the nasal mask just covers the nose, the oronasal mask that we commonly use in our ICUs, and the full face mask. The other is the nasal pillows. This is commonly used with the portable, the home ventilator, and the helmet NIV. Probably some of you all must have used during the COVID pandemic. Further look at the type of the masks, differences, the non-vented mask and the vented mask. So as the name suggests, starting from the non-vented mask, it doesn't have a vent to it. So it's for use on a conventional ventilator, which the ventilators who have their own exhalation system in place, and it requires the need of a dual limb circuit. And the identification would be the elbow is blue color. Whereas the vented mask, as the name suggests, it has vents to it, so there would be these vented areas from which are the exhalation ports, and these are to be used with a single length circuit on portable ventilators, and the color code would be the elbow is transparent here. A quick practical tip on the NIV mask. When switching between vented and non-vented masks, it can alter the carbon dioxide and the oxygen concentration. So we need to be aware which mask we are using, and accordingly dial the appropriate settings. Some masks do not have an inbuilt exhalation port, so we need a connector with a exhalation port. And when giving nebulization,
If you're going to give nebulization through a vented mask, the medication will leak out through the exhalation port. So for them, special adapters are available with the functionality of giving nebulization, MDI, and even doing bronchoscopy. So these provide the benefit of a closed circuit. A quick look at the circuits, the type of the circuits that are used on NIV. There are the single limb circuits and the dual limb circuits. Single limb circuits are actually used for the home NIVs, and they are less bulky. Only thing is there's a difficulty in monitoring the tidal volumes. And the single limb circuits usually have an expiratory leak port or an expiratory valve. Whereas the dual limb circuits, they provide more precise measurements of the tidal volumes and are used on the conventional ventilators or the critical care ventilators. A few other differences between the conventional ventilator and the portable NIVs. The conventional ventilator NIV is used on the ICU ventilators, the critical care ventilators, and they have highly monitored ventilation. The other advantage is that they have a wide range of respiratory support modes, superior alarm systems, and the good advantage is in case if the patient requires invasive ventilation, you just have to switch the settings and connect the patient to an invasive ventilation. The conventional NIV ventilators, they require dual limb circuits. Whereas the portable ventilators, they usually have just basic support. However, the newer ones do have, the newer versions do have varied modes. Only thing is they have limited monitoring capabilities, and we can use single or dual limb circuits on them. So what should we be aware when switching from conventional ventilator to portable ventilator? We need to assess the patient for stability of the airway, the respiratory and the lung mechanics, and hemodynamics. Look at the ventilator and the settings, the capabilities, the alarm systems, the connections. When the patient is connected to the tracheostomy tube, keep in mind the leaks, and patient and caregiver preparedness. So give a trial period when the patient is in the hospital to know whether it is suited to the patient or not, or else you may have to change the brand of the NIV ventilator. Train the patient if possible, or else at least a caregiver into airway management and also how to recognize the alarms. So we need to ensure that the portable unit, it meets the patient's clinical needs with proper patient ventilator synchrony, adequate ventilation, and appropriate settings. Alright. Now coming to the details of the NIVs, starting off with CPAP. FiO2 and PEEP help maintain the oxygenation. Yeah, we need. So CPAP, continuous positive airway pressure, it aids oxygenation only. CPAP continuous, that means there's only one pressure that is delivered during both inhalation as well as exhalation. And this pressure that is maintained even during exhalation, it helps keep the alveoli open, and thus it helps the oxygenation. Important thing is that all these breaths are patient triggered, and an apneic patient on a CPAP will remain apneic if the ventilator does not have a pressure support mode to it. Coming to the BPAP, the bilevel positive airway pressure. So to titrate ventilation, these are the two parameters that we need to dial for any ventilator: respiratory rate and tidal volume. Just keep that in mind. BPAP, as the name suggests, bilevel. So there are two pressures needed, IPAP and the EPAP. These are the two pressures that we need to dial on the ventilator. And this BPAP, it aids ventilation and oxygenation. The ventilation is affected by the difference between the IPAP and the EPAP, right? So greater the difference, that is greater the pressure gradient, it is called the pressure, the difference is called the pressure gradient, which generates a pressure support. So greater the difference, greater will be the size of the breath that's delivered, and greater would be the tidal volume. And thus increasing this gradient It helps improve the alveolar ventilation and washout of the CO2. Again, an apneic patient on BPAP will remain apneic until unless the ventilator has a backup rate, and this would be the ST mode, the spontaneous timed mode, and if there is no backup rate, it would be just the S mode, the spontaneous mode. There are advanced modes available. I'm not going to go much into details. I believe they'll be covered up in the workshop. So let's just move ahead. Steps for initiation of NIV. So initiating the CPAP, dialing in the CPAP is just one setting, that is the EPAP, which is also called the P. You just have to dial that. On a portable ventilator, it would be the dialing of EPAP, whereas on the critical care ventilator, the ICU ventilator, you have to dial in the P and keep the pressure support 0. So that is the CPAP. And looking at the BPAP, the bi-level, you have to dial in 2 pressures, the IPAP and the EPAP. So for the portable ventilators, you need to dial in the IPAP and the EPAP. And in case of the conventional ventilators, the critical care ventilators, you dial in the P and you dial in the pressure support above the P. Pressure support is basically the additional pressure beyond the P that is provided during inspiration. And you also need to dial in a backup respiratory rate. It's usually kept about 2 breaths or so below the patient's intrinsic rate. Initiating the NIV, EPAP and IPAP settings need to be adjusted in increments of 2 to 3 centimeters of water every 5 to few minutes, depending on the patient response. The exhale tidal volume should be about 6 to 8 ml per kg of predicted body weight, or until the respiratory distress improves. The trigger should be set sensitive enough to allow easy triggering without any auto triggering, even in the presence of leak. We should have a backup respiratory rate. There should be a pressure ramp and a maximum inspiratory time. Another practical tip, just a patient safety alert. So when you're putting the patient on the NIV, first dial the settings, switch on the NIV, and then connect the mask to the patient's face. There have been reported incidences wherein the mask has been connected to the face and people have forgotten to switch on the NIV, and that can be really disastrous. So switch it on and then connect it to the face. Other important practical tip would be explain the procedure and the reason for the therapy to the patient. Answer the questions that the patient may have, because this is a really discomforting type of non-invasive ventilation with a mask, before placing the mask on the patient. So just talk to the patient, reassure them before starting. Another practical tip, it should be a preferably low and a slow build-up. The higher the pressures that are used, the tighter the patient's mask will need to be, and the more tight the mask is, the more pressure the patient will get on his or her face, and that may cause more discomfort, especially in a conscious patient. So if the time permits, hold the mask, let the patient hold the mask if possible, or else you hold the mask to the patient's face with the NIV on. Let them just get used to it. Increase the pressures, and then strap the mask to the patient's face. Again, just let the patient get used to this, to the basic settings, and then gradually dial up the pressures. However, if the patient is in respiratory distress, give them as much therapy as they can tolerate as soon as possible. Titrating NIV. Titrate the EPAP or the PEEP to achieve the desired saturations. And if the PCO2 remains high, then increase the tidal volume. That means increase the pressure gradient. And if the patient requires a PEEP of more than 10 or an IPAP of more than 20, do reassess for intubation. Another practical tip, keep in mind, IPAP does not mean ventilation and EPAP does not mean oxygenation. So let's look at this example. There's a patient A with an IPAP of 15 and an EPAP of 10. Patient B has an IPAP of 12 with an EPAP of 5. So This patient has a higher IPAP. Would that mean that more CO2 is washed out? Well, let's look at the pressure gradient. This patient has a pressure gradient of 15 minus 10, that is 5. And patient B has a pressure gradient of 7, 12 minus 5. As we saw, higher the pressure gradient, greater the breath generated, greater the tidal volume, and greater the alveolar ventilation and more removal of carbon dioxide. So even though patient B has an IPAP which is lower than patient A, but the gradient is more, and that's what comes into play. Rather than the absolute numbers, it's the gradient that is important. Another bedside tip, when you increase the IPAP, that would help increase the tidal volume, increase the ventilation and wash out the CO2, especially for hypercarbic patients. When you increase the PEEP or the EPAP, it helps the oxygenation. However, if you increase the EPAP without touching the IPAP, that would reduce your pressure gradient and can lead to a buildup of the CO2, and FiO2 would affect the oxygenation. Just a quick look at a few examples. 45-year-old male, acute coronary syndrome, pulmonary edema, and the patient is on non-rebreather mask. This is his ABG. So now you would initiate him on which mode of NIV? The pH is 7.38, PCO2 is 41, so there is no ventilation problem at the moment. However, the PO2 is 50, that means yes, the patient does have oxygenation issues. We can start the patient on a CPAP, convert from NRBM to CPAP, gradually titrate up, adjust the FiO2 also to affect the oxygenation. Sometime later on, if you find that the patient is using his accessory muscles of respiration and he has an increased work of breathing, you get an ABG done and you find that the PCO2 now has increased and the PO2 has marginally improved from 50 to 60, right? So that's when we, now the patient also has a ventilation problem, and that's when we consider switching to BPAP. And this is because CPAP provides one pressure, BPAP would be bi-level 2 pressures, and CPAP doesn't help clear the carbon dioxide. Another example, 65-year-old male, COPD exacerbation on BPAP mode, 11/5, and he is actually breathing over the vent, and these are his ABG numbers. So what settings should we change? Now this patient has respiratory acidosis, that means has a ventilation issue. What would be changed? The respiratory rate and the carbon dioxide. Now this patient is already breathing over the vent, so there is no point, increasing the rate is not going to help. And hence we need to affect his tidal volumes. The current pressure gradient is 11 minus 5, that is 6. And hence we need to increase the IPAP to increase the pressure gradient. Let's say we increase the IPAP to 15, that becomes 15 minus 5, and we increase the pressure gradient to 10, and that would help wash out his CO2. Another case, 66-year-old lady of community-acquired pneumonia. On BPAP, these are the settings, and the patient is again breathing over the vent. And these are her ABG values. She has hypercapnia and she's also hypoxic. So what settings will be changed? This patient has both oxygenation issue and a ventilation issue. For the oxygenation issue, we'll touch the PEEP and FiO2. So PEEP, we can increase the EPAP or the PEEP from, let's say, 4, we increase it to 6, and we increase her FiO2. From 40%, you can just increase it to 100, 60, whatever, depending on the saturation. So that's the oxygen taken care of. And now coming to the ventilation portion. 2 settings, respiratory rate, tidal volume. Patient is already breathing over the vent, so increasing the rate is not going to help, and hence again we come back to our pressure gradient, that is increasing the IPAP. So we increase the IPAP, make it 12, and we've already increased the PEEP, that was 6. So now the pressure gradient is 6. From an original of 4, we've increased the pressure gradient of 6. So this is how we keep on titrating and titrating the patient. Another patient, 50-year-old lady, community-acquired pneumonia with acute coronary syndrome, and this patient is on, these are the ventilator settings, the BPAP settings, and this is her ABG result. Patient has an oxygenation problem. We're going to increase the EPAP or the PEEP from 5 to 10, and also increase the FiO2 SiO2 because her PO2 is on the lower side. Now, for the ventilation issue, this patient has a current pressure gradient of 15 minus 5, that is 10. After changing of the settings, if you increase the EPAP and if you leave the IPAP as it is, the pressure gradient would actually decrease to 5. She already has a borderline PCO2. So that would actually further increase her carbon dioxide levels, and that's when we have to increase her IPAP also to improve the pressure gradient. Now, which of the following ventilator settings would most likely result in rebreathing of carbon dioxide? A high EPAP or a PEEP of more than 6, EPAP of less than 4, IPAP of more than 6, and CPAP of more than 6. You just think in your mind. Alright, so PEEP of less than 4 can lead to rebreathing of carbon dioxide. We'll see in the next slide. So how can we minimize rebreathing of carbon dioxide? EPAP, as we saw, is the pressure that is applied during exhalation to keep the airways open. If the patient has a low PEEP or a low EPAP on the NIV, this will affect the adequate purging out of the carbon dioxide, and that would accumulate in the patient's mask and the tubing. And hence, we need to keep EPAP also on the higher side to prevent rebreathing of the carbon dioxide. Dual limb circuits, increasing the pressure gradient are other ways to minimize the rebreathing of CO2, and avoid masks with large internal volumes, that is a full face mask or the helmet mask. How can we improve the patient tolerance? So the non-respiratory factors that may increase the respiratory drive, for example, pain, fever, any metabolic acidosis, they need to be assessed for and corrected. There are different type of masks now available, better masks, patient-friendly masks available to ease the comfort. As can be seen in the video, there are masks with rotating interfaces and even adjustable headpieces. So you can use that to improve the tolerance. We've all come across this pressure source on patient's face. So gel masks are available, silicone nasal pads are there, and even the use of mepilets that we use for pressure source or the deoderms, they can also be used over the pressure areas on the face. Other ways to improve compliance would be chin straps and even the usage of auto ramp. That is, you dial in the pressure, you dial in the ramp time, that is within how much time the maximum pressure would be reached, and the same thing is when at the time of exhalation. Other ways to improve tolerance to the mask, especially in ICU patients, would be the use of sedative medications, Dexmed, ketamine, fentanyl, or IV haloperidol, and even benzos. But keep in mind, pharmacologic agents, to reduce this respiratory drive, they can be used, but they reduce the respiratory drive, and they should be used cautiously and with monitoring. Right, coming to the monitoring, we need to look at the patient. The patient comfort would be seen in the form of decrease in the respiratory rate, decrease in the work of breathing, and improved patient ventilator synchrony. Looking at the ventilator would be looking at their exhale tidal volumes, a minute ventilation. Avoid peak pressures more than 30. Look for patient ventilator synchrony. This would be seen in the form of clinical assessment and even graphics that will be taken over by the next speaker, and also monitor the patient's blood gas. A practical tip, it's important to treat the patient and not the numbers. So please see the patient, assess the patient, look at the monitor, look at the patient, talk to the patient. If you feel that the patient is sleeping, maybe he's sleeping, maybe not, maybe the patient is hypocarbic and just going into respiratory failure. So try to wake up the patient and talk to the patient. Frequent evaluation by multiple providers in your unit will definitely help, and the team needs to discuss their observations. And the goals should not be an immediate improvement again in the numbers. So let's look at another case. There was a lady with COPD exacerbation who had severe dyspnea and with a respiratory rate of 40 per minute. She was started on BPAP, and after some time you find that she looks much better. Her rate has come down to 24 per minute from 40. However, a repeat ABG after an hour doesn't show much change. So should this patient be intubated because the ABG doesn't show any change? It has been seen that BPAP can be successful even without an immediate improvement in the ABG. Sometimes the ABGs, the numbers may lag behind as compared to the clinical improvement, so keep that in mind. And would this be considered a BPAP failure? Actually no, this would be a BPAP success because the patient has clinically improved. And this non-invasive support devices are actually a bridge to until the medical therapy has its effect. Weaning. There are no standard weaning techniques. Two ways: increase the time of the mask ventilation, and the other thing would be to gradually reduce the IPAP to a minimum level to let the patient assume more work of breathing and then gradually discontinue. Another practical tip for the home NIV, use masks that have a dedicated oxygen port rather than having a cannula pass between the mask and the face. That would actually add to the leak and add to the discomfort of the patient. Nearing the end, integrated approach. So this combined strategy is used as a bridge to avoid invasive ventilation by managing patient symptoms, improving oxygenation and protecting the lungs. Both the modalities, HFOT as well as the non-invasive ventilation, have complementary benefits. There is no one device that's always meant for a particular patient. Some patients may need a switch, and both the modalities, as we saw, they help decrease the work of breathing, reduce the patient effort, and they prevent lung damage. So when you need a high peak info, let's say for example a patient has severe hypoxemia, low PF ratio, then you can consider switching from HFOT to NIV. Again, ABG values are not needed to determine which device to use. It is the clinical diagnosis and your clinical assessment. When should we consider invasive ventilation? So studies have shown for non-invasive ventilation, a longer duration of NIV before intubation was associated with a decrease in the hospital survival. And for patients who are on HFOT, early intubated patients had better ICU mortality. Which are these patients? Those in whom their respiratory parameters do not improve, they have poor mask fit, there are leaks, they are not cooperative, the underlying condition worsens, they become hemodynamically unstable. That's when you consider switching over to invasive ventilation. But again, keep in mind, late intubation is associated with worse outcomes. So finally, the success of the non-invasive respiratory devices, it depends upon selecting the correct therapy, monitor for patient tolerance, adjust the settings without causing any complications, monitor for signs of ventilator failure, and customize as per the patient need. To conclude, there is definitely a role of physiology in the care of critically ill patients. Initiate early. These devices are just short-term strategies to buy time for medical therapy. And in case if the patient doesn't improve, switch over to invasive ventilation. Thank you.
Thank you, ma'am. Any questions? So it was a wonderful lecture, ma'am. We are physicians and we understood it very well. We are not intensivists, but the practical tips and the ease was very good. Thanks a lot, ma'am. Any questions anyone has? Ma'am, one thing, when do we use the ventilated mask in the ICU? Yeah, the vented mask.
we would avoid using the vented mask in the ICU if you're using the conventional ventilators, unless the patient has their own portable ventilator. You can continue using the vented mask because it has an exhalation port. Whereas for the conventional or the critical care ventilators, you'll be using the dual limb circuit.
So we don't use
that
the
would be a
vented mask.
non-vented mask.
Yeah, so vented masks only for
For the
portable
portable ventilators.
Ma'am, could you just add a special note for emphysematous patients or people having flail chest, any variation or anything?
Again, it would be basically monitoring of the patient. A flail chest, I'm not sure. We would be using the NIV. If at all there's an oxygenation problem, maybe consider HFOT. And in case if it's used for a flail chest, you'll have to keep on monitoring the patient clinically, what's happening inside, or else switch over to, depending on the patient's response, consider invasive.
Thank you. Thank you, ma'am, for the wonderful session. I would request Dr. Vineet Srivastava to please felicitate Dr. Sonali, ma'am. Thank you, ma'am. Moving to the next short session for the lamp lightning. I would like to welcome Dr. Aparna Methil, ma'am, Chief of Medical Services at Terna Speciality Hospital. Ma'am, please. Dr. Sandeep Agarwal, sir. Dr. Nikhil Varghese, sir. Dr. Ashwin Bhosle, sir. Dr. Archana, ma'am. Dr. Vineet Srivastava, sir. I would request Dr. Aparna ma'am to please speak few words.
Good morning, everyone. At the outset, I would like to welcome all of you on behalf of Terna Speciality Hospital and Research Center. Happy to see you all on this rainy day. I think I would like to congratulate Dr. Sandeep, Dr. Nikhil and the entire ICU team for this academic feast. Hope you will have great interesting topics for next 2 days. I think what we started as a small case discussion has been culminated into an annual property. Now we have come to this stage wherein we are conducting live workshops. Hopefully, maybe 2-3 years down the line, we can have a dedicated conference. Considering the academic interest of our clinical team, I'm very hopeful that we will have dedicated conference. On the hospital front also, we are growing very rapidly. We are adding 2 more floors to our existing building. Plus, we are coming up with 2 new establishments in Mumbai and across Mumbai and Navi Mumbai. So I'm not taking much of your time. Once again, welcome you all for this academic feast. And I would like to thank my entire clinical team and marketing team for their support. Thank you so much.
Thank you, ma'am. Moving on to the next session. This session will help us understand how to diagnose and manage asthma and COPD patients in day-to-day practice. So for this session, I would like to invite Dr. Sandeep Agarwal sir, HOD in Critical Care Department at Terna Speciality Hospital, author of book MCQs in Critical Care and Clinical Cases in Critical Care, teacher and examiner of IDCCM, co-founder and director of Ease Life Healthcare, started with Advanced Critical Care course for nurses and certificate course in Fundamentals in Critical Care.
Hello. Okay. So this one is going to be little interactive, right? So this is going to be, so till now you have had lectures on airway management
camera stand
from and NIV. From now on, all the lectures are going to be very clinical, which are going to help you in your day-to-day life. So all the things that you face, all the difficult cases, all the problems which are real life problems that you face in your daily practice is something that we are trying to address from now on, right? So this is going to be interactive. I would like you to participate in this. So we will start with the case. So an old man, chronic smoker, COPD. He came with new onset symptoms, new dyspnea, some new chest infiltrates, increased sputum production. So when he presented, his heart rate was high, 120, respiratory rate is 24, his saturation is 88% on room air. His first blood gas was done, which showed acute respiratory acidosis, right? So this patient, as Dr. Sonali said, all the COPD exacerbation should be given the NIV trial. So this patient was given NIV trial, but his apart from regular medical therapy, so his respiratory rate increased to 32 to 36. Another ABG was done, another say in a couple of hours, which showed that PCO2 has increased, pH has decreased, and that is why it was decided that we should intubate this patient using fentanyl, rocuronium, and propofol. And a big size tube, which is 9 mm cup tube, was placed specifically because the bronchospasm and airflow limitation has to be tackled. Just to show you a quick recap about the indications for mechanical ventilation in COPD patients. Major criteria: respiratory arrest, loss of consciousness, hemodynamic instability because of COPD exacerbation, gasping, bradycardia, impending respiratory or cardiac arrest. All these are major criteria for invasive mechanical ventilation in COPD patients. Then there can be minor criteria, which can be high respiratory rate, worsening acidosis after say 2 hours of medical therapy, and so on. Okay. Now you have intubated this patient, COPD patient intubated. What are your goals of mechanical ventilation? Anybody? So the first is to maintain adequate oxygenation, correct? Second is to reduce and minimize hyperinflation. This is the biggest culprit, biggest villain in the COPD patients. Hyperinflation. What is it? How to detect, what to do with it is something that I will stress upon in the next slides. Controlled hypoventilation. This will also something that I will stress upon. And the last one is provide rest to fatigued respiratory muscles. So these are our goals of ventilation in the initial part. So how do we give rest to muscles? By giving sedation and minimal paralytic agent if needed, and do the controlled ventilation. Okay, so one of you intubated this patient and they have put him on this ventilator settings. So which is respiratory rate of 18, tidal volume of 450, PEEP, IE ratio of 1:2.5, because they know that there is some airflow limitation. So the expiratory time was kept little higher. Now, is it enough? We don't know. So we will have to see the graphs. Now this was the flow time graph which you got after your intubation. Right? This is flow time graph. Is there any problem with this? Are you happy with this graph? Any problems you can see? Anyone? Anyone? Sorry? Correct. She is right. Absolutely right. If you see the expiratory flow, we have that marker. Marker. Okay, anyways. Can you see this? So this is inspiratory flow and this is expiratory flow. Can you see this expiratory flow has not reached the baseline and the next breath has started. Okay, which means the previous tidal volume which you had given had not come out of the lung and you have given the next breath. Okay, how is it going to be problematic? We'll again see that. So what should be your initial goals of mechanical ventilation? The first one is to maintain adequate minute ventilation, but should not be very, very high. So minute ventilation of 115 ml per kg is enough, which means for a patient of say 50 kg, it will be around say 5.5 to 6 liters of minute ventilation. It is enough. Keep a tidal volume of 6 to 8 ml per kg, not very high tidal volumes. Keep a respiratory rate of 10 to 14. Would you like to keep respiratory rate of 10 to 14 or higher? Because what do you want to do? The patient had PCO2 of 68. Don't you want to wash it out? Do you want to wash it out or not? Obviously, I want to wash it out. Hai na? So precisely that is something that you don't need to do. Keep inspiratory flow high. Keep IE ratio of 1:3 or higher. Keep an optimal PEEP. What is optimal PEEP? We will see. And the most important thing is do not try to normalize PCO2. So this is one thing that I feel is something which everyone tries to achieve, and it is the worst thing that you can do. Do not chase PCO2. Do not overventilate the patient in an attempt to normalize PCO2. So this is another graph showing the same problem, where you can see the breath taking. So if you see, this is the normal tidal ventilation. Can you see this? If you hyperventilate the patient, do not allow the previous tidal volume to come out, what is going to happen is this thing. So this tidal volume was trying to come here, but had not come out completely, and you have given another breath. So that is going to add up to your previous tidal volume. See, tidal volume is going up after each and every breath. See, this is called breath stacking. If breath stacking occurs, what is going to happen? This is going to cause, which is called dynamic hyperinflation. Imagine some amount of air being left in the lung, which is not coming out, and you are pumping another and another and another round of tidal volumes. So which is going to cause barotrauma, which is going to cause pneumothorax, which is going to cause a number of problems, which we will see further. So this is primary, basic, fundamental issue with any type of obstructive airway disease where you are going to get dynamic hyperinflation. So dynamic hyperinflation is going to create all the kind of problems which may be a mechanical problem, gas exchange, neuromechanical uncoupling, and serious cardiovascular effects. Okay. So dynamic hyperinflation is going to cause what? It is going to lead to increased work of breathing. Now the patient has to overcome, if in a spontaneously breathing patient, the patient first has to overcome the dynamic hyperinflation, and then only they will be able to trigger the next breath, which is going to cause, so the patient has to put more and more effort. Any patient who is breathing at higher rate, COPD, who has very poor muscular reserves, they are usually cachectic. Now we are putting them on increased work of breathing because of dynamic hyperinflation, which is eventually going to lead to respiratory failure. So another thing is the intrathoracic pressure is going to increase because of increased lung volumes, and expiratory lung volume, EELV, and expiratory lung volumes are going to increase because of retention of air. So this is going to create increased intrathoracic pressure leading to decreased venous return and left ventricular compliance. So this is going to create problems with your hemodynamics also. So this may result in hypotension in a patient who was hemodynamically stable. You thought that blood pressure is okay, I will be able to intubate him very easily, giving him propofol or something, because propofol is a good drug to intubate COPDs and asthma, but that can lead to increased incidences of hypotension. Another important thing is ineffective triggering, because now the patient is trying to breathe, but because of increased intrathoracic pressure, the patient is not able to trigger. So this will lead to dyssynchronies. Obviously, increase and expiratory lung volumes are going to create pneumothorax, pneumomediastinum, and pneumoperitoneum may occur. There is high incidence of dead space. Now, if the dead space fraction has increased, the carbon dioxide is going to increase. For that, the patient will breathe, will put more effort. So, work of breathing is going to increase because of increased dead space fraction because of dynamic hyperinflation. Now, if dynamic hyperinflation is so bad, how do I know patient has dynamic hyperinflation? This is theoretical part till now, that dynamic hyperinflation is a bad thing to have, and we have to know that. So we have to manage that. So if we want to manage anything, we need to detect it. Anybody can tell me, I have written it here वैसे, but can anybody tell me how to detect dynamic hyperinflation? Okay. So first one is clinical cues. Clinically, how to suspect dynamic hyperinflation in obstructive airway disease. So if the patient is unnecessarily tachypneic, disproportionately tachypneic, patient using accessory muscles, there is unexplained hypotension on ventilator. So these can be your clinical cues. Now you are suspecting that one of the causes can be dynamic hyperinflation. So what do? See for ventilator graphs. Now first graph I have shown you, the expiratory flow not returning to baseline, which is very easy to see, which will show you on workstations also. So if you see that, that is a very easy, very obvious clue to dynamic hyperinflation. Then there is elevated baseline pressure, which is your elevated plateau pressures. Unexplained elevated plateau pressures is another clue which can give you an idea about the dynamic hyperinflation. Then tidal volume stacking, which I have shown you on the graph, which you can see. Then can you measure it? Yes, we can measure the dynamic hyperinflation. What exactly are the levels, which I will show you just now, and how to measure it. And then only you will be able to correct it. Okay, this is another nice graph which is going to show you the effects of dynamic hyperinflation. Is it improving? Is it increasing? Worsening? Is it creating complications? This is something that you can see on very easy graphs. So this is pressure time graph on a volume control mode, right? So the first graph that you can see, first one is peak pressure, then plateau pressure. In second graph, there is increased bronchoconstriction and airflow limitation. So if you can see that plateau pressures have remained same, right? So if you see that in a patient where you had intubated and the graphs are like this, so there was some peak pressure, there was some plateau pressure. Now your plateau pressure has remained same and your peak pressure has increased, right? So that will give you an idea about increased airway resistance. So plateau pressure is a function of lung compliance, which is alveoli, and peak pressure is a function of dynamic resistance, which is to the flow of air. So if airway resistance increases in relation to flow, then your peak pressure will increase, but your plateau pressure will remain same. In the third one, you can see peak pressure has also increased and plateau pressure has also increased. Correct? I told you if there is a breath stacking, there is going to be an increased end expiratory lung volume, right? Which is going to increase your plateau pressure also. So if you see a graph where your plateau pressure has increased and your peak pressure obviously will increase, then you can suspect additional and increase in end expiratory lung volume, which means dynamic hyperinflation or a pneumothorax, right? So how do I know in a patient being ventilated that the patient has developed pneumothorax? We know that there is a complication of pneumothorax. So this is one of the ways to suspect it. It is not a confirmatory thing, but if the patient who was doing well, a stable one, not fighting with the ventilator, hemodynamically stable, your plateau pressure increases, suspect a pneumothorax. Okay. Another graph of breath checking. On the right hand side, you can see the expiratory flow reaching the baseline. Can you see that? But in this patient, breath checking is shown by the expiratory flow graph not reaching the baseline, and in the volume time graph also you can see that the baseline is not touched, and in the second one baseline is higher, which is showing breath checking. Okay. Now we have understood that dynamic hyperinflation is bad. How to suspect? Can we measure it? Can we measure it exactly? How much dynamic hyperinflation, or in other words, the commoner word is auto-peak. Can we measure auto-peak? Yes, we can. So how we can measure it is by using expiratory breath hold maneuver, right? First one is use expiratory breath hold maneuver, which is all given in your ventilators. There is a button for expiratory hold. So press it for 3 to 5 seconds and you will see this kind of graph. Can you see this graph? So this is a normalish graph, peak pressure, plateau pressure going back to your baseline peak. With expiratory hold, this is going to increase like this. You can try it in your patients with obviously supervision. Okay, try this and you will be able to see your peak baseline rising. Now to whatever level it rises is your total peak. You can minus your external peak that you had applied. In previous example it was 8. So if your total pressure increases beyond 8, 8 to what you had applied. That will be your total PEEP including auto PEEP. So 8 is something that you have applied, and say for example total PEEP comes to be 12, so your auto PEEP is 4. That gives you an idea about measurement of auto PEEP. Is there any other way? Yes. In a volume control mode, you can, if you try that, you can increase your PEEP levels, but your plateau pressure levels will not rise if there is a presence of auto PEEP. Again, if you increase your PEEP levels, if there is auto PEEP, your plateau pressures will not rise to a level where both the pressures are going to be together. Again, say suppose your you have kept a external PEEP of 6, for example. Now you have increased your PEEP level to 8. Your plateau pressure should also rise by 2. If it is not increasing, that means there is a presence of auto PEEP. Now keep on increasing by 2. The point where it increases plateau pressure, that is your amount of total auto PEEP. That is how you can do that. In spontaneously breathing patient, you can also use esophageal pressure changes for detection of auto PEEP. This is also important. If you paralyze the patient completely, do a long expiratory hold, right? Allow all the air which is stacked inside the lung to come out and measure that amount. So if that is more than, which is called end inspiratory volume above functional respiratory capacity, which is VEI. So if it is more than 20 ml per kg, this is the only measure which is predictive of hyperinflation related complications such as hypotension and barotrauma. So this is also something you can try in your ICUs, again in supervision. Okay. Now patient was given adequate sedation and medical management was done. So now we had seen the graphs. We know that there is dynamic hyperinflation. We have measured dynamic hyperinflation also. Now what to do? How do we correct the dynamic hyperinflation? Okay. So why dynamic hyperinflation is coming? The only reason dynamic hyperinflation or auto PEEP is coming is because all the inspired gas has not come out. Okay. So you have to give it adequate time for the inspiratory gases to come out completely. So that is the crux. Now how do you do that? Because inspiration is in your hands, expiration is going to be passive. Expiration is always going to be based on the lung mechanics. Now a patient has bronchospasm. You have given the patient all the kind of therapies, but it does not resolve immediately. So you have to deal with the constricted airways, right, and collapsed airways. So what do? So provide the longest expiratory phase that is possible. How do you provide the longest expiratory phase? You reduce the patient's ventilatory demand and minute ventilation, contrary to what you have been doing. So you have been trying to reduce PCO2 by increasing minute ventilation. Now I am saying reduce the minute ventilation. Okay, obviously you are giving bronchodilators and steroids. So how do you reduce the expiratory, how do you give the longest expiratory phase? Last thing is keep the plateau pressure under 30. Okay, keep the plateau pressure under 30, which may be achieved by maintaining low tidal volume, low minute ventilation, and obviously correction of auto PEEP. So how are we going to, I think that this is on the next slide. So to achieve expiratory phase, what do? So ventilator settings are adjusted to volume control mode, which is preferred. Why volume control mode is preferred and not pressure control? Well, I would prefer. You can do ventilation with pressure control also, but there are problems with that. Say suppose the bronchospasm changes. bronchospasm improves or worsens. Your tidal, because of pressure controlled ventilation, your tidal volumes are going to go haywire. You will have to continuously monitor those tidal volumes, right? Based on the compliance and resistance of the lung, the tidal volume are going to change, which is, you may be feeling that the pressures are controlled. Now patient is not going to go into barotrauma, but patient can go into volutrauma or hypoventilation. So use volume control mode. Keep initial respiratory rate of 10 to 14. So we have kept it at 12. Tidal volume of 450 ml, which gives you a minute ventilation of around 5.5 liters per minute. PEEP of 8, and keep IE ratio high. High means, how do you decide 1:3, 1:4? By looking at the flow time graph. So increase your IE ratio looking at the flow time graph. If your baseline is touching, that is the setting that you want to do. Keep a peak pressure alarm of 80 centimeters of water. Can we keep our peak pressure alarm to 80 centimeters of water? Can we keep? Yes, we can. Very easily we can. Right? So peak pressure is a function of airway resistance, major airway resistance. So your lungs are not going to get damaged by peak pressure. Your lungs are going to get damaged by high plateau pressure. So in an obstructive airway, since you are increasing very high flows, your inspiratory pressures are going to be high anyways. So if you are going to set your ventilator 1:3 or 1:4 IE ratio, which means inspiratory time is going to be short and expiratory time is going to be long. If your inspiratory time is short, the airflow is going to be high. For high airflow, resistance will always be high. And that is why if you keep your alarm settings at 40 in volume control mode, the volume control alarm will be triggered and the patient will not be ventilated at all. So this is one small thing that you should see and practice, because the rest of the things you will do and still you won't be able to ventilate the patient. So keep your peak pressure alarm to 80 or higher, right? And in spontaneously breathing patient, use flow triggering rather than pressure triggering. Same graph. If you keep your peak airway pressure alarm at, say, for example 40, which is the commonest one, your peak pressures are going to be high. Anyways, it is going to be high if you are ventilating the patient in a high IE ratio setting. So you should keep it at very high level, 60, 70, 80, whichever is needed. If you see in this graph, your peak pressures are high, yes, but your plateau pressures are very less. So there is going to be a huge gap between peak and plateau pressure, which is expected, right? So peak pressure is high, but keep your plateau pressures under 30 centimeters of water. So that is something that you need to do. These are another, this is another slide of similar things. So if you see, the last thing that we want to see is keep the absolute expiratory time 4 to 5 seconds. Say for example, if you are ventilating a patient with respiratory rate of 20, right, with IE ratio of 1:2. So one respiratory cycle is going to be 3 seconds. 1 second would be inspiration, 2 seconds would be expiration. Correct? Now reduce it to 12. Right? If you reduce it to 12, your one respiratory cycle is going to be 5 seconds. Okay? If you keep it 1:4 IE ratio, you will have inspiratory time of 1 second and expiratory time of 4 seconds. In that setting, you were keeping expiratory time of 2 seconds. Now you are keeping it at 4 seconds, which means you are allowing more time for all the inspired gases to go out. Correct? That is the crux. I will show you. So ABG was done, right, which is in front of you. Okay. So let us say PCO2 has increased. Now the patient came with 62, patient had PCO2 of say 68 and you intubated for high PCO2 and now the PCO2 is 72. So you will say, sir, क्या आप समझा रहे हो आप, ये तो और गलत हो गया, PCO2 तो और बढ़ गया. Correct? That is the question. So that is precisely you should do. Again, if PCO2 goes up, let it be. Again, I am telling the goal is not to normalize PCO2. It is to prevent and minimize autopeep and dynamic hyperinflation. PCO2 will fall back in place at some point of time. Otherwise, if you chase PCO2, you are going to worsen the patient in most of the cases. Now, should you chase PCO2 or should you chase pH? Should always, in all the patient, all kind of pathologies, everything, the body detects, reacts only and only to pH and not to PCO2. Always remember that. If your pH is, so that is why in your ABGs, the first thing that is given is pH. All your ABG interpretation starts with pH, not by anything else. So pH is the most important thing. Now, target a pH. So what is the pH? If you know the baseline, most of the times COPD patients have lowish acidotic pH. So if you know that, maybe you can try and achieve that. If you do not accept acidemia, let PCO2 be higher, but do not try to normalize PCO2. What kind of pH you can accept? Maybe 7.2, 7.25, up to that, seeing the hemodynamic stability and the rest of the things. You should always keep your patient in mild acidemia. Allow permissive hypercapnia. Okay, if you, because I am telling you to go it will decrease, it will help you in decreasing hyperinflation. It will not cause patient to go into high VD by VT, which means high dead space. It will reduce the hemodynamic instabilities. It will reduce the chances of barotrauma, which are more important. Disadvantages, atelectasis, hypoxemia, respiratory acidosis, which can be there, but there are contraindications always to permissive hypercapnia, which are elevated. Come back to that. So we have kept in the initial slides, in that case, we had kept an external PEEP of 8. Do we always need to keep PEEP? You always keep a PEEP, right? So I had used a word optimal PEEP. So what is the right amount of PEEP? Can we find it out? PEEP of 3, 6, 8, 10, 12, arbitrary. Can there be a logical, scientific way of applying external PEEP? Yes. How? Okay. So why we need to apply external PEEP? This is first thing that we need to know. If you see the first one, this is specifically for COPD patients. In COPD patients, apart from the constriction of expiratory flow, there is always a collapsibility because of chronic inflammation. The terminal bronchioles will always have poor cartilaginous structure and they will collapse. So if because of increased autopeep, there is high intrapleural pressure, it is going to cause the collapse of airway here in the expiration. Now, if in expiration the intrapleural pressure is 8, okay, this is an example. This is 0. The flow of air should be from here to here, right? But because of external pressure here, because of collapsibility of the terminal alveoli, terminal bronchioles, these will collapse. Even though there is a pressure gradient, there will not be any airflow. So what the patient need to do is increase the, so in a spontaneously breathing patient, how do we breathe spontaneously? By creating a negative intrapleural pressure, right? So that pressure has to be higher than your auto peak. So in this example, for example, if the intrapleural pressure was already high, which is around 8, the patient need to maintain negative pressure more than 8 for the flow of inspiratory air. The patient may not be able to create expiratory flow. Patient may not be able to create inspiratory flow despite the effort. That is typical of COPD. Now, if you are applying 6 cm, again in this case, which was this one, if you are applying 6 centimeters of extrinsic PEEP, now see here it was 0, here it is 6, this is 8, this is 6, this causes a sort of stenting effect. Stenting effect to the collapsibility of the airway, which creates expiratory flow. Now here if you see, the effective intrapleural pressure is -2. Here it was -8. Now the patient has to, even if the patient generates intrapleural pressure of -3, there will be generation of inspiratory flow. Otherwise here it has to, patient has to increase the intrapleural pressure more than 8, and then the airway flow will increase. That is why the external PEEP is important in COPD patients specifically. So external PEEP makes it easier for patients for inspiratory PEEP to trigger the ventilator. It reduces the work of breathing. By stenting the collapsible airways, it causes an expiratory flow, just like the pursed lip breathing. You know, you must have read pursed lip breathing in COPD patients. Why do they do similar kind of breathing? They create sort of stenting effect, which we are creating by applying external PEEP. Okay. Now, should we apply PEEP in asthmatics also? Because that is also obstructive airway disease. So this is one typical difference between COPD and asthma. Rest of the things, rest of the principles are similar in COPD and asthma, but in asthmatic patients you do not apply PEEP. I will show you why. So if you see key takeaways, in asthma the obstruction is because of fixed narrowing. The external PEEP is not going to help it. It is rather going to worsen the flow of air. In COPD, because of the collapsibility of airway, the external PEEP is going to create a stenting effect, which is going to create the better ventilation of your airway. Second part is the resistance. In asthma, the resistance to flow is in line, and in COPD it is a parallel one, which means if you create a pressure here in asthma of say external PEEP of 6, this is going to create resistance to the flow because it is 6, it is not 0. Keep it 0, which is called ZEEP, ZEEP, 0 and expiratory pressure in asthma is something that you should do. Now a question comes, say I have talked about permissive hypercapnia. So you have done permissive hypercapnia and still the patient is not getting ventilated, or the pH drops to 7.1, or permissive hypercapnia is contraindicated. I showed you the contraindications, right? So what do we do? So there is something which is called extracorporeal CO2 removal. This we can discuss in a later slide tomorrow, probably in ARDS section, but basics are that you put the patient on an extracorporeal circuit, not like ECMO. So ECMO is much more invasive, much more demanding. It is a very simple system where the purpose of whole of the system is to remove PCO2 from the blood, which will take care of your PCO2, and you continue with your ventilation so that your lungs are not harmed. Now, over next 2 days, patient has improved, secretions have dried up, getting better. Now, should you start thinking of weaning the patient from ventilator? You have intubated, you have to take it out also. So when should you think that the patient is better and now I should start to? So you should start thinking within 24 hours. Within 24 hours of intubation, at least start thinking of weaning. Earlier you wean them, earlier you take out the tube, better would be the outcomes. So usually in 36 to 48 hours, bronchospasm, diaphragmatic fatigue, muscular fatigue, they all settle. The acidosis, this and that, all those different kind of issues with the patient usually settle. And then you should definitely think of weaning. So the cause of exacerbation has been treated, whether it is heart failure related or infective, has it been addressed adequately or not? Hemodynamic stability, optimal acid-base electrolyte balance, minute ventilation of less than 15, RR of less than 30, tidal volume more than 325, compliance of more than 22, static compliance of 33. So these are the criteria. Now, how do you wean these patients? So, what are the commonest ways of weaning a patient? TP trial and pressure support, right? In COPD patients specifically, do not use TP trials. More likely they are going to fail it. In most of the patients, use pressure support trial with some PEEP, because there will always be some amount of dynamic hyperinflation. With some external PEEP, you will be allowing patient for a better triggering and more better desynchronies. So do not use TP style. Other methods that you can use are proportional assist ventilation and NAVA. Second thing is, if you are using pressure support ventilation, you know about flow cycling. So I told you that the most important part in COPD with expiratory flow limitation is to allow them maximum expiratory time, right? In volume or pressure controlled ventilation, you can change IE ratios. How do you change IE ratios in spontaneously breathing patients? In pressure support, is there an IE ratio setting in pressure support ventilation? There is no setting. So how do you increase IE ratio? So this is something that you can do. If you see the flow cycle, so in pressure support there is flow cycling. Flow cycling means if the flow, peak flow is, say suppose 60, the flow has started to slow down and it has become 10% of your peak flow. The patient will go from inspiration to expiration. So that is called flow cycling. Cycling means going from one phase to another phase. From inspiration to expiration is cycling. So in pressure support mode, it is always flow cycling. So if you increase if you see this, if you increase it from 10%, by default most of the ventilators will have 25% of flow cycling, which means when the flow rate reduces to 25% of its peak, it will go into expiratory phase, right? So what you can try and attempt is, in these patients, you increase your flow cycling to 50%. Okay, so if you see inspiratory time has reduced, can you see this? Inspiratory time has reduced, right? It may help you in increasing your expiratory time. May means, why I am saying may, because everything is not in your hand, because the patient is spontaneously breathing, but this is one thing that you can attempt. So in Mackay getting a ventilator, this is where you can see your inspiratory cycle. So this is 15%, you can increase it to 50%. Something about NAVA and proportional assist ventilation, I think that these in detail are going to be covered tomorrow in advanced mode section. So these two modes are also available for weaning the patients of COPD. Difficult weaning, yes. COPDs can always be very, very difficult. You may do whatever. The patient may be very catechic, may have other kind of comorbidities, sometimes bronchospasm, secretion, they do not go. Whatever medical therapy you do. So this can cause difficult weaning. So if there is, so it is said that if you cannot wean the patient in 2 to 3 days, the patient is going to take longish time and it is going to be difficult always. So always check other causes of difficult weaning, which are size of endotracheal tube. You remember in the first slide of case, patient was intubated by 9 mm cuff tube. Usually most of the ICUs we intubate in by 8 number tube. So in COPD, obstructive airway diseases, use maximum size tube. Check for circuit issues, kinking of tube, acute angle connectors, all those things should be optimized. Always check for core pulmonary. Because of COPD, many of the patients will have higher pulmonary pressures. They may go into core pulmonary, and that may be the reason of weaning failure. As soon as you put your patients to increased work of breathing, the heart fails and leads to weaning failure. Then finally, tracheostomy. So role of tracheostomy is not very well defined in COPD patients specifically. When you should do, what is the optimal time, till what time you should attempt weaning, that is difficult to say. But on case to case basis, you should attempt tracheostomy, which helps in weaning and removal of secretions also. So this is one slide which covers or summarizes all the things that I've said about from intubation to extubation. Last very important thing is consider, last one, post extubation, consider prophylactic non-invasive ventilation or high flow nasal cannula or both to prevent re-intubation. So remember this, many of your COPD patients will do very well if you extubate them and put them on NIV straight away. Do not check for anything else. Put them straight away on NIV and your re-intubation rate will reduce drastically. There is some data about high flow nasal cannula also, but the data is not as robust as NIV.
Hello.
So extubate and extubate to NIV.
Hello.
Okay. So last slide. To sum up, the primary fundamental physiological problem in obstructive airway diseases is worsening of expiratory airflow limitation. And that is the primary thing that you have to address, which the second most important thing is to detect, address and manage the dynamic hyperinflation or autopeak. Okay. Minute ventilation should be adjusted to pH and not to PCO2. This is the commonest mistake I see. Commonest. I'm not taking names, but even in my ICU, when I come in morning, I do yell, why you have kept your respiratory rate to 24. So sometimes they keep it to 24 just to wash out the PCO2. Okay. Keep the plateau pressure less than 30 and you can keep your peak pressures very high. You can. There is no problem with that. And frequently monitor ventilatory waveforms, which are going to give you an idea about how your lung mechanics are working now. Right? So there may be an improvement in your obstruction, there may be worsening of obstruction, there can be a pneumothorax, which is, or a barotrauma in some other form, pneumomediastinum or something, which you can easily and early detect by ventilatory graphs. Thank you so much.
Any doubts?
Any doubts? There will be a lot of doubts if I start to ask.
Yes, sir. So I had this doubt when I was in my post-graduation in 2009. We had a ICU posting. I was under Dr. Sameer Jog in Mangeshkar Hospital, Pune. So he used to come and set the I ratio to 1:3, 1:4. I used to think that will accumulate the PCO2. And I always used to think, why is he doing that in an emphysema or a COPD patient? He never answered me, but today it got cleared. So, so it will happen, you will have some doubts.
So, your best friend, if you are talking about ventilator, is your graphs. They give you everything, all the data about the patient. You don't need to see many of the things. So all those IE ratios, this and that, how to set 1:2.5, 3, 4, or whatever settings that we want to do, is based on graph. Right. So we have a session on graphs where has she come? Where Dr. Gunjan is going to give you all the idea about lot of graphs, and that is going to be a really good session. I hope my 2-3 points are very clear to you. One is, do not increase the respiratory rate, do not chase PCO2, and reduce your minute ventilation. So, thank you.
Thank you, sir. I would like to request Dr. Nikhil Varghese, sir, to please felicitate Dr. Sandeep Agarwal, sir.
तो पेपर में जाओ दे
I would like to request Dr. Nikhil Varghese, sir, to felicitate our chairpersons, Dr. Ajay Kukreja, sir, Dr. Resham Kukreja, ma'am, So now we will have a short quiz session. Let's see how much you have learned in this session. So Dr. Nikhil Varghese, sir, will be conducting the quiz session.
वो आपने को नहीं लेनी है
You had two great sessions this morning. In the morning we dealt with airway problems, and then we had NIV, HFNC, and ventilation in obstructive disease. So let's test your understanding of today's topic by a short quiz. So some of you must be familiar with how Kahoot works. We have some limitation only. I think few participants will be able to join in. So first come first. Download or log into Kahoot site, take the pin and join it. So many of you are already exam going students, so probably you will be able to take your some extended assessment today. Once you have 10 participants, will move out to the quiz. We got 5. Nine, 10. Okay, so let's start. Yeah, people can keep joining, no problem. We'll start with the quiz now. This is a demo slide, just to see how you are voting. So your time starts now. Okay, so you got the knack. Now let's start the quiz. Sorry, I think we'll have to go back. Take one more minute and re-log in, please. Sorry for the inconvenience. Re-log in. The game pin is 461228. Okay. Which of the following is the most reliable indicator of airway obstruction in an unconscious patient? Cyanosis, stridor, gurgling sound, and inability to speak. Vote fast, 10 seconds left. Okay, so there is a confusion among the participants. I think many people think stridor is the reason, but inability to speak is the most appropriate answer here. Okay, let's go to the next question. The lemon mnemonic is used for predicting difficult intubation. What does E stand for? So edema, evaluate 3-3-2 rule, epiglottis visibility, endotracheal tube size. Okay, so yes, now most of people have answered it correctly. Lemon is a mnemonic for evaluating 3-3-2 rule, which assesses mouth opening, mandible length, and laryngeal position. Move to the next third quiz. Which of the following is not part of Malampatti classification? Visibility of soft palate, visibility of uvula, neck mobility, visibility of tonsillar pillars. I hope this is much easier. I hope most of the people will get this right. Yes, almost correct. Neck mobility is not part of it. In trauma patient with suspected cervical spine injury, the preferred airway maneuver is head tilt, chin lift, jaw thrust, neck extension, cricoid pressure. So you have to do a maneuver which should be safe, as the patient is expected to have cervical spine injury. Yes, jaw thrust. Jaw thrust is a safe maneuver to do. We cannot do head tilt, chin lift, and we cannot do neck extension. Fifth question. Which of the following findings suggest upper airway obstruction? Wheezing, stridor, crackles, bronchial breath sounds. Yes, best. So I hope the topic was very clear. Which is the most appropriate initial step in assessing airway patency in an unresponsive patient? Check oxygen saturation, inspect for chest rise, perform a jaw thrust, look, listen and feel. Okay, oh, people want to inspect for chest rise. The correct answer is look, listen and feel, which is a triad helping you to quickly assess the airway patency and as well as the breathing effort. Which of the following is a red flag for impending airway compromise in ICU patients? Hoarseness, tachypnea, use of accessory muscles, drooling and muffled voice. Okay, use of accessory muscles. See, we are talking about airway, you are talking about general breathing. We are talking about airway. That's why the answer is drooling and muffled voice, because it suggests supraglottic obstruction and requires immediate airway evaluation. Which of the following is a contraindication for NIV? Now we have moved to the NIV station. Moderate hypercapnia, alert and cooperative patient, facial trauma, COPD exacerbation. I think this was very clear talk, so answer should be very much there. Unanimous decisions, huh? Facial trauma, great. So there will be some exciting prize for the winner, don't worry. Which of the following is not a benefit of HFNC over conventional oxygen therapy? Better humidification, reduced dead space, increased work of breathing, improved patient comfort. So correct, increased work of HFNC reduces the work of breathing, and that's why it helps. But if the competition is getting stiffer, this is the last quiz. In which condition NIV is most beneficial in ICU? ARDS with PO2 by FiO2 ratio of less than 100, cardiogenic pulmonary edema, severe asthma with silent chest, and massive hemoptysis. Again, I think the answer was very clear in the morning talk. Correct. So acute conditions like cardiogenic pulmonary edema probably are a better situations where NIV can be used, and other things are here. Obviously, the NIV will be failed. Thank you for your participation. I hope you understood the topic well, and the winner can meet Dr. Manjeet Kaur backstage for the prize. Who's this? Can you raise the hand? YK. Okay, fine. Only 1 kilometer to the prize, so no problem.
Okay. I think so everyone are hungry now. So we'll move on to the lunch ready outside. And I request everyone to resume within 35 to 40 minutes.
रेकॉर्डिंग बंद का ठीक है.
We will resume back within 35 minutes for the last session.
येस सर बोला ना. घाई घाईत मला बोलवलं नाही. ये आहे तसं फास्टमध्ये. अरे मग काय एक जण खाल्ले गेले टॉयलेटला. उमेश इथं सरांनी बोलवलं ना. आम्हाला आतमध्ये दे एक बॅगच दे बरं.
हे वेफर खाल्ले का? वेफर खाल्ले? पोट भरलं का? नंतर काय? अगरबत्ती लावायची. मोहिनी आहे? मोहिनी? वागिरे.
कितना बड़ा प्लॉट चाहिए? 3-4 एकड़ बहुत बिल्डिंग बनना ना उसके पीछे हमने क्या एक साल पहले का कम होता मालूम है क्या?
वही तो अच्छा भाव कम था कभी कुछ नहीं था अभी भाव बढ़ रहा है.
मेरे पास इतना था बहुत था मेरे पास. मैं पहले एक काम कर देंगे मेरे दोस्त ने 7-6.5 पेटी भी मारा उसके पीछे खड़ी
मंत्रालय में कोई भी काम रहेगा लो ले कुछ बोलना अपने को इतना बड़ा कॉन्टेक्ट है.
मैं कुछ साथ में क्या हूँ मैं जगह लिया हूँ मालूम है वो तो बड़ा कॉम्प्लेक्स बनाया उसके पीछे जगह था एमआईडीसी पूरी एमआईडीसी है एक प्लॉट में था लेकिन उसमें कंपनी का चलता है
खाली प्रॉपर्टी का
नहीं जमीन तो लैंड का लैंड साथ में करने का लेकिन एक भी भाजपुर में बहुत था लेकिन एक दोस्त एक ने गेम किया 4-5 के साथ में काम करने के इसने तो बड़ा पैसे लेके भाग गया उधर ही ले गया हमने भी पैसा काम किया पैसा भी दिया जमीन के बारे में लेकिन अभी एक सीढ़ी के बाद 12 घंटे का तो आसपास 7,000 का उसमें सीढ़ी ने ऑलरेडी कर दिया है फार्मा को पैसा भेज दिया है और एक बार फार्मा से एग्रीमेंट बना के लिए उसमें तो कुछ नहीं करता है
पैसे सीढ़ी ने पैसे दिए
फार्मा को
किस एग्रीमेंट
एग्रीमेंट बात नहीं अपने जो हम से था वो दोस्त का ही एग्रीमेंट किया 10 पेटी दिया
प्रॉब्लम क्या है
10 पेटी मिल रहा नहीं है लैंड भी है
बोल रहा हूँ मेरा बहुत बड़ा अधिकारी है
सीट को बहुत सब पहले पैसा मिली है खत्म भी कर दी है
देखो समझा खर्चे करेंगे
सबकी पड़ेगा ये वो प्लॉट थी वो प्लॉट 50 को डॉक्यूमेंट दिया था
कैसे होता अगर मैं आपसे ज़मीन मैं सिर्फ को आपसे ज़मीन देने के बाद मुझे और कुछ भी नहीं किया क्या बनाया
कुछ ऐसे पड़ा लेकिन फार्मा
किसी ने अगर मैं आपसे ज़मीन दे दिया और वहाँ पर कुछ भी नहीं बना तो वापस खुद कर सकते हैं वो कानून है
ऐसी कैसी पड़ा जब पास में कुछ नहीं
करते बोले लेके आओ काम कर सकते हो
पैसा
कितना लिया था बाद
कितना पैसे तो मालूम
पहले पूछो ना फार्मर ने कितना पैसे लिया था दिया ना 10 लाख रुपये दिया.
Hope so everyone has lunch. We'll resume back to the session with the last talk of the event. For this last session, I would like to invite the chairperson, Dr. Archana Matre ma'am, HOD in Anesthesia Department, Terna Medical College, and Dr. Madhuri ma'am, Associate Professor in Anesthesia, Terna Medical College. This session will make easier to understand ventilator waveforms and loops and how they can help us monitor and manage patients better. For this session, I would like to invite Dr. Gunjan Chanchalani to our session. Currently as a Director Critical Care Medicine at Wockhardt Hospital, Mumbai Central. She serves as a Vice President, ISCCM. Welcome, Dr. Ma'am.
जय सांभाळ कैमरा भी लिया कैमरा भी लिया कितने का
So good afternoon everyone, and before the screen starts, I think maybe I can start waking you all up because it's post lunch session and good time to doze off. I think there are few more people who are coming. So you all have had the first part of the session today, which was about ventilators, right? So what do you think has changed or evolved as a ventilator in the last few years?
Okay.
So when I was a student or when I started my career 20 years back, I may not look so old, but 20-25 years back when I first used a ventilator, they were bird ventilators. They used to like just pump in air and bring out air. There was absolutely no understanding of how bad or good the lung was. We had to set a tidal volume. And the amount of sound that ventilator did to pump in air was really bad. Okay. And of course I worked in a setup where that time where there were hardly a couple of ventilators, but there were no displays. And we would not understand what exactly is happening to the patients. And that eventually increased the mortality on the ventilators, the understanding of how we are going to balance what the patient really needs and giving the personalization, and what is the problem in the lungs. What is the problem in the lungs, so that we can modify our settings accordingly, so that we can give the best output or protect the lungs. So what really evolved as a lung protective ventilation for the ARDS patients is actually a lung protection which we have to consider for every patient whom we are ventilating. So though the terminology is only for lung protective, our graphics tend to help us understand how we can protect the lung so that we can have a safe, allow the lung to heal and safely wean the patient off the ventilator. So looking at a graphic itself from a distance, we can understand whether the patient is happy with the ventilator or not happy with the ventilator. So we evolved from going from a control mode completely to going to a assist control mode because of these graphics and understanding the mechanics, or maybe modifying the tools how the ventilator delivers the air to the patient, so that we can keep the patients less sedated. Nowadays there are even talks of keeping the patients off sedation even when we are giving them lung protective ventilation. It's like awake ventilation that we are talking of. So the ventilators have tried to understand what speed or flow of air needs to be given, how much needs to be given, and how much needs to be removed. Ye chalu hoga, or I can just verbatim talk. So we cannot learn loops and graphs without seeing the loops and graphs, but we can still discuss. Since it's post lunch, can you all raise your right hand up just to wake you all up? Can you all shake it? This is my left hand. Okay. All of you all can stand up and shift to a seat on the right. One seat to the right. We'll come back in the middle of the session to the left so that I am sure everybody is awake. जो नहीं उस समय उठा मतलब वो सो रहा है. तो थोड़ा लेट मैंने किया, थोड़ा लेट ये ऑडियो विजुअल वाला कर रहा है. पॉइंटर है क्या? हाँ? पॉइंटर.
साउंड इससे गायब जा रहा है. अपना साउंड नहीं आता ना इसमें.
So when we look at a mechanical ventilation on the screen, we see two types of graphs. Commonly when we see the older ventilators, they had nothing. Then they came only with the scalars, and now they come with loops. And now there are intelligent ventilators. The artificial intelligence has got into our ventilators long back, so there was closed loop ventilation. But now they are more intelligent to understand the compliance and the resistance of the lung and accordingly decide how much is to be ventilated. So the newer Hamilton ventilators that they have are actually, you have to just feed what is the age of the patient, what is the weight of the patient, what is the average height of the patient, and they will judge what is the compliance and the resistance of the lung and decide to deliver the ventilation according to the pathophysiology of the lung. So it really takes our brain off, but by the time we start using it, I mean, I'm sure I would have retired and all of you all must be towards the retirement by the time every hospital has those ventilators. So it is important that we today sit back and study the scalars and the loops. So when I talk of scalars, the x-axis of the scalars is always the time. Okay, so we are seeing everything against the time. And what there are three parameters that we are seeing against the time is the pressure, the flow and the volume. Okay, it is very easy to understand a volume scalar if you can see the last one. In that, during the inspiration the volume increases and during the expiration the volume goes down. Now you may say it is increasing, but this is the measurements that are happening in the ventilator or which are shown on your screen are actually at the ventilator end. Okay, they are not at the patient end. So though it is showing an increase, it is basically the amount of volume of air that the ventilator gave away and then what it received back. Okay. So if I simply say, if I am looking at a volume time scalar, there is not much to see. I just have to see that both the sides are equal, that whatever the ventilator gave has to come back. Now if I see this volume not coming back adequately, that means what? It got lost somewhere in the path. Either the lung did not give it back because of the resistance, or there was a leak somewhere where it got lost. Right? So that is how we will know the changes and when we see the scalars. Now I look at flow and the pressures. The look of this flow and pressure will change based on what mode you have used. If it is a volume control mode, the volume is stuck, is fixed. The flow, the pressure will change as per the lung, and based on what volume we have decided or told the ventilator to give, it will keep the flow static. Okay, so volume control was the most primitive mode that it started as. So what was taught to the ventilator at that time or fed to the ventilator at that time, that if a person tells you, if the intensivist tells you that you have to give 500 tidal volume in 2 seconds, you have to modify the flow in such a way that 250 goes in 1 second and next 250 goes in 1 second, another second. So it cannot modify the speed. So that is why the ventilator learned to give us stagnant flow, and that is why it is called as a square flow. So this is actually a volume control mode which is shown. And based on how bad the lung is and how much effort or the work the ventilator is doing to give that flow to the patient, that is how the pressure will change, and that will give us two readings of the pressure, which is louder, peak pressure and the plateau pressure. So the peak pressure is when the flow is active, and if I give a pause, inspiratory pause, when there is no flow, it will give me a plateau pressure. So peak pressure will tell me how bad the lung airways are, and the plateau pressure will tell me how bad the lung alveoli are, or how good the airways or the alveoli are. When we talk of the loops are going to see now two dynamic parameters. They are going to compare two dynamic parameters. One is the pressure volume loop and the other is the flow volume loop. Okay, here again the volume is the constant part, though it is variable. It may vary as per the mode. Like in a pressure control mode, the volume varies. Because the volume varies, the flow varies. The pressure is what remains static. Okay. So again with the volume, either you compare a flow, or with the volume you compare a pressure and you generate the loop. Now how the loops look? So this is when you look at a pressure volume loop, the second part will always come on the y-axis. Okay. So the pressure will increase gradually to overcome the initial compliance, or you could say also when the flow starts, there is resistance also which has to be overcome. Beyond one point, when the alveoli open a little, it is like a balloon. When we blow a balloon, the balloon opens up slightly, and it is easier for us to inflate that balloon. And so initially the pressure starts going up, and beyond the point, the increase in the volume is faster, but the change of the pressure is not much. Okay, because our work reduces and the alveoli open up much easier. And this lower point where the curve happens is actually the lower inflection point. Sorry. So this is the lower inflection point where my arrow is. So beyond this point the alveoli are easy to open. So the alveoli have opened up slightly and now it is easier to open. So what is the purpose of this lower inflection point? It is telling me that beyond this point the alveoli are in the best compliant phase, and I need to keep my PEEP at least above the lower inflection point so that my alveoli open up more easily and more effort is not put to open up. If I put more effort to put it up, or if I need more pressure to every time open the alveoli, I may also cause atelectotrauma or maybe barotrauma as well, and all this process will cause biotrauma by increasing the inflammatory mediators. So we need to keep our PEEP above the lower inflection point at least. When the expiration is starting, initially the volume remains the same, but the pressure reduces because suddenly the pressure has dropped. Okay. But when I'm increasing the volume further, and at a point where there happens a beaking, which we'll see further, okay, where if the alveoli are getting overinflated, at that point during the inspiration, when they're overinflated, the volume will not increase as much, but the pressure will increase faster. So there we will see the upper inflection point. In a normal lung, the upper inflection point probably doesn't have much significance, but when we see a beaking kind of appearance, where it becomes narrower, that will tell us that now probably I have started over-distending my lung. Okay, we'll see the abnormal ones as we go forward, but just understanding the significance. Okay, when we give a PEEP, obviously my alveoli starts up at the little farther away, and here probably my lower inflection point will not be so obvious. These are diagrammatic representation, so don't go by the curve, but when I make my PEEP above the lower inflection point, my curve is comparatively much smoother than what it is shown in this figure. Okay, so we already spoke about this. So as I said, the initial part of the whole box or the curve that you can see between that loop, okay, the whole shaded area is actually the work that is done. The initial lower part of the work is the lower part is mainly overcoming the airway resistance, and the upper part is mainly overcoming the elastic recoil of the lungs, and that is the green part, that is the elastic work that is being done. When we talk of the flow volume loop, again the volume remains on the x-axis and the flow remains on the y-axis. Here the inspiration is above and the expiration is below. The flow, whenever we are talking of flow, we have to look at the smoothing of the flow, and we have to see if the flow is smooth or not smooth. And here mainly it helps us understand the expiratory flow, because when I'm looking at when we talk of a ventilation, when we are giving putting a patient on an invasive ventilator, we are actually giving inspiration as active, our expiration is still passive. So the active inspiration, if my peak inspiratory flow rate is comparatively lower, okay, that means there is a lot of compliance issue, okay, and because there is no pressure to tell me, okay, how badly that flow has affected the pressure, the inspiratory curve probably here does not have much significance. But when I'm looking at a flow compared to a volume on the expiratory side, it is going to tell me what is the T constant, what is the time constant for expiration. So when I talk of time constant, maybe in obstructive airway disease, Dr. Sandeep must have spoken about it. So when we say time constant is when every alveoli is different. It is not going to be a single alveoli that everybody has the same inspiratory time, same compliance, same resistance and the same expiratory time. So every alveoli is different in its own characteristic. By maybe millimicroseconds, they inflate at their own speed and deflate at their own speed. So when you combine all of them together, you come to terminologies called as time constant. So when I say one time constant of expiration, that means 63% of the alveoli will empty in that one time constant. And for a mathematical formula, one time constant is resistance multiplied by compliance. So if I say a normal resistance is approximately 0.2 and a compliance is 10, then my time constant is 2. That is 2 seconds. Okay, it is not so high, but normal time constant for expiration is about 0.5 seconds. Okay, but if you say for obstructive airway disease, what will happen? The resistance will increase. The resistance probably will become 50, and the compliance has probably remained 2 itself. So now my one time constant has become 25. Okay, so my amount of 63% alveoli emptying is probably very high. Okay, so that is the reason why in obstructive airway disease we have a lesser respiratory rate. Let us not go there. But here when you see the peak expiratory flow rate, and if you see there is a smooth emptying of the alveoli to 0 by the time where the inspiration started, that means the expiration has been proper or it is smooth. If there is resistance, then we may see a flattening of this curve with a concavity in the initial phase. Again, we will see the abnormalities as we go forward. Okay. This is a pressure time scaler where you can see the initial part, that is the inspiration is negative and the expiration is positive. That means this is everything is available online. Kuch bhi photo mat lo. Just register in your brain what I am talking. I will send you all the PPTs. Okay, ये सब मैंने online से उठाया. Just that I have shuffled and arranged it myself. That's it. So don't put all your brain and grey cells to see and understand rather than taking pictures. Okay, it should be like when I finish the talk, you should be able to draw the graphic. Okay, so when I am talking of this initial inspiration, if the inspiration is negative pressure generation, that means is it a patient ventilator induced breath or is it a spontaneous breath? So this is how a spontaneous breath will look if I am measuring on a normal patient. So when I am looking at all the three scalars, the pressure is going to be negative for inspiration, and then the flow is going to be sinusoid. It is neither going to be square nor is it going to be decelerating flow, because we tend to take the inspiration as a smooth inspiration. Okay, but expiratory flow will still be a decelerating flow, because when I expire, it is again a passive movement where it is going to go as a pressure gradient. Okay, so when I am expiring against, if the pressure inside my lungs is 5 and outside is 0, the initial flow will be faster, and as the pressure in my lungs starts reducing, the flow will start dropping down. So the expiratory flow will be decelerating, so that there is a peak expiratory flow, and which keeps going slowly up into touching the baseline. And the inspiration, as I said, will be sinusoid. Pressure time scalar, it will show a negative pressure deflection because it is a negative pressure ventilation, and towards expiration, because there is positive pressure already in my lung because of the tidal volume which I took, it is going to show a positive deflection, and the volume is going to be the same. So I am just, for a spontaneously breathing patient, we are just measuring at the ventilator end how it would appear. Okay, so this is just overlap of the same thing. Now when I say a mechanical ventilated breath, that time in a mechanical ventilated breath, it is a positive pressure ventilation. Okay, unless there is a trigger, which we will not talk of now, we will talk of as we go forward. So there, initially the ventilator is going to give a positive pressure from the inspiratory side. So the pressure is going to rise, as I said. It is going to reach a peak inspiratory pressure point, and then it is going to drop as we start to end the inspiration. Okay, but if I am going to give a pause, it is also going to plateau, which is going to show as a plateau pressure. So to understand a ventilator, we have to define the ventilator based on 4 terminologies. Okay, any mode when we talk of, you have to define of 4 terminologies. It is basically you have to feed 4 things to the ventilator, and you have to interpret the things as per the 4 things, and based on that, all your asynchrony and everything will be very easy to understand. So we have to tell the ventilator when to initiate the inspiration, what to do during inspiration. So when to initiate the inspiration is called the trigger. What to do during inspiration is what the inspiratory phase does, wherein we talk the control variable that we have or the limit variable that we have. So it can be volume control, or it can be pressure control, or a pressure regulated volume control, whatever, we come to that later. Then we tell the ventilator when to switch from inspiration to expiration, which is called as cycling. And lastly, what to do during expiration. Okay, what to do during expiration is very simple because it's again passive. So all we have to decide is how much peak to set based on how the graphic display is. And the other things again we set or understand as per these 3 variables. Okay, so the expiratory changes from expiration to inspiration is called as triggering. And triggering is again of 2 types, the flow trigger or the pressure trigger. Then in the expiratory phase, it is mainly the peak. Inspiratory phase is the limit, as I already said, it is volume limit, pressure limit, or maybe any dual modes, and change from inspiratory to expiratory, which is again either time cycled, volume cycled, or flow cycled, which would be there. Okay, so this we already discussed. Volume time scalar, that is the inspiratory part of the volume and the expiratory part of the volume. Okay, the peak inspiratory pressure, and inspiration and expiration. So now you have to tell me the abnormalities. So where is the peak inspiratory pressure? The topmost. Where is the plateau inspiratory pressure? The second peak that is seen. So what do you think is the problem here? High plateau pressures as compared to the peak. Okay? So because the plateau is high, maybe the lung compliance is poor. Okay? The lung elasticity is bigger. Okay? Any confusions in these terminologies? not go into these definitions. What is happening here? The resistance peak inspiratory pressure is much higher than the plateau inspiratory pressure. Right? So probably there is a problem with the resistance. I think only 3 people are there in the class. The others can start raising their hand. How many are sleeping? Koi haath nahi uthaya. So they are actually sleeping. How many are awake? Okay, 2 people are awake. Okay, so 60 is the louder. 30 is the, what is the likely problem? Airway resistance. Very good. That is, first question mark is the P plateau. What is the likely problem? Poor compliance. So the first type of graph will be seen in which pathophysiology? COPD. And the second one? ARDS. Now when I look at the flow time, this is a square flow. That means what will be the mode of the ventilation? Pressure control will be square pressure, because your pressure is the limit. Here volume is the limit. In a volume control, so that means the flow is the limit. Volume and flow go together. You can't limit the volume, you are limiting the flow. Right? So, as I said, it will be a square waveform on the flow parameter. So the peak inspiratory flow will be constant throughout the inspiration. Okay, so depending on what volume you have set and what inspiratory time you have set, the ventilator will decide what peak inspiratory flow I want to deliver, so that I maintain a square waveform. Okay, and during expiration, it's a passive process. Irrespective of the mode, it is a passive process. So initially it is going to have a peak expiratory flow, which is slowly going to decay down, causing a decelerating flow pattern. Okay? Expiratory flow. So there are 4 types of flow patterns which are available. The first is a square flow, which I already said, which is in the volume control mode. Second is a decelerating flow, wherein if I keep the pressure constant in the inspiratory phase, my flow is going to drop, because as the alveoli inflate, there is going to be some amount of pressures which are going to develop inside the lungs, and the pressure on the ventilator side is static. So now the gradient will reduce and the flow will start dropping. Okay. Then there is accelerating flow, where we are pushing the flow into the ventilator. So APRV modes, as we may call, say, if they may have an accelerating flow pattern. And sine wave flow pattern, where did we see this? Sorry? Spontaneously breathing patient. Very good. So guess the mode. Fast. Louder. Which mode? So the pressure is changing, flow is constant. Square flow. Anyone? Volume control. Answer aa gaya tha kya? What is this? So first wave is a spontaneous breath. Second wave is a triggered breath, right? Because he's tried to generate a negative pressure. But the pressure time waveform, if I see, it is kind of a volume control. So it is a SIMV volume control breath. Here every breath is triggered. Okay, so it is a assist control mode. So every breath is being assisted. Here only some breaths are being assisted. Fine? Which mode is this? There is a plateau in the pressure time scaler. Pressure control. So in pressure control, what is the harm? That you are setting one constant pressure. Okay? In that pressure, if there are secretions in the alveoli, or if the tube gets blocked, that pressure will not be delivered to the lungs, or the pressure difference will cause the volume to drop. Okay? So this is one disadvantage which is there. So that is why if you're having a pressure control mode, you should, and kya hota hai, in the night the secretions keep accumulating, nobody suctions, the volumes keep dropping, and suddenly at 3:30 AM there is desaturation, someone goes and increases the FiO2, which doesn't make a difference because the volume is not getting delivered in the lung. So if you don't realize this as a problem, the patient will arrest by 4 AM, and then it is like 4 AM ko mere har patient arrest ho jata hai. Okay, so this is the main complaint that we have in our ICUs. Every patient dies at 4:30 AM. So if you put on pressure control, this is the common scenario which we have. Another problem with the pressure control is, suppose the patient is having severe bronchospasm. So I may set a pressure control level of 20 to deliver a tidal volume of 400. But I have kept nebulizing that patient constantly. I have told the nurse, please keep nebulizing for next 1 hour constantly, don't stop, because he's having almost a complete silent chest and a severe bronchospasm. So in that case, initially with my 20 pressures, I was delivering 400 tidal volume. As the bronchospasm starts giving way, so the amount of volume that we deliver will be much higher. And then one of the blebs will rupture after an hour, and there's a huge tension pneumothorax and another arrest. Pata nahi kyun arrest ho gaya. So pressure control mode is very dangerous unless you are keeping a watch on the tidal volume. So to overcome this danger, especially in resource limited settings, one mode which is commonly used is the pressure regulated volume control, or PRVC that we call it. Okay, where it is volume is guaranteed, and the patients and now the ventilator decides to modulate its pressure as per the pressure that you have set in the alarm limit. Okay, it will modulate its pressure up and down to deliver the tidal volume which you have told it to guarantee. Okay. What is it? So I have not given the name of the scalar, but looking at the trace, what do you feel? It is a pressure scalar, pressure time scalar. There is an inspiratory negative, and it is almost a square waveform. So it's a sinusoid kind of pattern, which is a pressure support. Okay, every breath is supported. It could also be assist controlled pressure control. Okay. So this is again pressure support. The pressure support is constant throughout. As per the patient's effort, the flow may fluctuate up and down, and the volume may fluctuate up and down. Okay. Again, if there is a blockage or if there is pulmonary edema which reduces the compliance, then in those cases the flow will drop with the same pressure support, or the patient gets tired, then in that case the flow will drop and the tidal volume will drop. What is here? There are two breaths which are spontaneous in center. There are two breaths on the side which are controlled breaths. They are non-triggered breaths. The middle two breaths are not supported. So we already saw this mode. Sorry? SIMV. Intermittent mandatory ventilation. So it is intermittent mandatory, it didn't synchronize with the breath. It is just mandatory breath which was it. Here it synchronized. So it is SIMV. Okay? It triggered and it just synchronized every breath. They were unsynchronized. We don't have IMV modes on any ventilator now. Okay? Here in the synchronized, this is SIMV plus pressure support. So whereas spontaneous breath is occurring, it is giving a pressure support. Okay, that was plain SIMV, it was not supporting the spontaneous breath. Here it is supporting the spontaneous breath. There is a PEEP which is set, whereas every breath is unsupported as a spontaneous breath. So this is a CPAP mode. Okay, we don't usually put it on an invasive, but just to understand. So how does PEEP work? PEEP, again as I said, it will just keep your alveoli open slightly so that it is easier to inflate further. Okay? Relative contraindications I will not go into. Now coming to what is inspiratory and expiratory time. Okay, as I already discussed, based on your time constants, you have to decide your inspiratory and expiratory time. So in ARDS, the inspiratory time constants are prolonged because it's a poor lung. You have to poor compliant lung or lung which has a huge elastic recoil. It takes time to inflate them. So the amount of alveoli which will inflate in some amount of time will be comparatively lesser. So to allow 100% of the alveoli open, you have to give an inspiratory 3 times the inspiratory time constant. Similarly, in an asthma or a COPD patient, because the expiration is prolonged, the expiratory time constant will increase and you have to give a higher expiratory time or at least 3 times the expiratory constant of that lung. Okay. So usually we give a inspiratory-expiratory ratio of 1:2. But in ARDS patients, in case it is really difficult to ventilate, apart from recruitment, as one of the methods which was earlier propagated was the inverse ratio ventilation, wherein the inspiratory time was prolonged and the expiratory time was reduced, with an attempt to increase the mean airway pressure and to keep the alveoli open, to allow all the alveoli to open and allow good gas exchange. But nowadays, with the advent of prone ventilation and probably ECMO, inspiratory ratio ventilation is what we don't do. Whereas in COPD or asthma, you have to increase the expiratory time so that you allow complete expiration or the expiratory flow to come and touch the baseline. Okay, as much as we can. But again, there are studies which have shown that if you increase the expiratory time beyond 1:3.5 or 1:4, it doesn't have any advantage. So if you increase this to 1:5, 1:6, it doesn't give any advantage because last only 5% of the alveoli actually deflate, which doesn't help. Okay, so as you keep increasing the inspiratory time and decreasing the expiratory time, your alveoli will become more and more bigger. But then when you set the optimum peak, this is all tackled. So IRV is now out of go. Okay, what is happening here? Which scalar is this? During inspiration and expiration, it is all positive. Okay, it didn't go on the negative side, right? So then it would be what? Only one graph which was on the last one, which is the volume time scalar. In the volume time scalar, as I said, whatever volume is delivered has to come back. Here it didn't come back. It got lost somewhere. That means it got lost somewhere. Probably there is a leak. In a flow time scalar, if you see a leak, it will appear like this. Okay, because for the ventilator, the flow did not reach back. Okay. If you look at the loop, okay, this is how a normal loop looks. Okay, and it is a flow volume loop. So in the inspiratory phase, it delivered the volume, but in the expiratory phase, the volume did not come back. It got lost somewhere. Okay, whereas if I have a obstructive airway disease, the volume will still keep coming back. So in that case, this orange line will come and touch here on the yellow vertical line in the lower part. Okay, so this is one difference which you need to know from your exam point of view. If it is coming to 0, away from the point of intersection, that means there is a leak because the whole volume has not come back and the flow has reduced to 0. Right? Here the flow is continuing. If the flow is continuing and the volume has not returned back to its normal, that means there is a resistance or the expiratory resistance or bronchospasm that you could say. Okay, this is again the leak. The volume did not come back. The volume got lost. Right? The pressure reduced to 0, but the volume did not come back. And the pressure volume zero. What is happening now? The dotted is the normal. Sorry? I can't hear you. Auto peep, yes. So there is flow restriction or complete expiratory flow has not returned to 0. Okay. So there is auto peep or air trapping which is happening, which is seen in resistance. So this patient needs bronchodilators. So the first graph should show an auto peep, but it is not showing an auto peep. Here the peak expiratory flow rate is lower. After bronchospasm, the peak expiratory flow rate has improved and my expiratory constant has reduced. So my resistance has reduced and my expiration is much faster than what it is seen in the first phase. Okay? What is happening? The same thing. Okay, in the first orange, the peak expiratory flow dropped, and the next orange it increased again after active expiration. Okay, this we already saw. Any confusions in this? If you all don't understand this, probably you all will not understand the asynchrony. Okay. So what is happening here? Air trapping again. Here the flow has reduced to 0. The flow is still there. The volume has, the volume is still there inside and the flow is also continuing. It has not come to 0. So there is air trapping. The expiratory constant, time constant is so prolonged, patient is continuing to expire though the expiratory time is over. Okay, so it is the better term is air trapping. So actually where there is air trapping, there would also be a peak expiratory flow drop. And often when the patient is, if he is awake and tries to actively expire, you may also see a concavity, which is there in the flow volume loop. Scooped out pattern is what it is called. What is this? Anyone? You see this often, again at 4 AM. There are a lot of secretions in the circuit and the secretions are more often seen in the expiratory phase, again because it's a passive process. So when it's a slow passive process, the secretions will choose to give vibrations. So this is a normal lung, is the white one, and in the green one, if I am saying that for the same volume, the amount of pressure required is more to give the same volume, that means my lung has a good compliance or a bad compliance? Bad compliance. So if my lung compliance reduced, I may see a lower slope. Okay. In a volume targeted ventilation, it may appear like this, that the pink is with a higher pressure same volume is delivered, yellow is with a lower pressure same volume is delivered. So as I am going from yellow to green to pink, my compliance is getting worse and worse. Whereas if I see in a pressure targeted mode where I am keeping the pressure constant, okay, my volume has started to drop as my compliance has worsened. Right? So yellow is a good compliance. Because my pressure is constant, my volume will start dropping. My volume will not remain constant. In the previous one, the volume was constant, the pressure was increasing because it was a volume control ventilation. This is the beaking that I was talking of. So if I try to give a volume higher than the point, the green line which is there, that means now the pressures will increase whereas the volume will not change. Okay, so if I am trying to overinflate, my alveoli, they will try to increase, the volume won't increase because there is no compliance. They don't have the capacity to dilate. But that pressure will be transmitted to the other alveoli or to the whole of the lung, which will harm the lung or cause barotrauma. Okay, so I don't have to exceed. This is mainly a ARDS lung with a poor compliance, where I have to ensure that my volumes remain such that there is no beaking which occurs. So my volume should be lesser than the upper inflection point. Okay, coming to dysynchrony, before we start dysynchrony, I want everybody except these three people stand up and move to the right side of your chair. Just to ensure how many are awake. So those people are not even getting up, so they are definitely sleeping. Only these three are awake, they are actually responding. वो लास्ट वाले अभी तक नहीं उठे बॉस. Okay. So coming to dysynchrony sounds very difficult to understand, but actually if you try to see the basics and understand it, it is very easy to understand. Okay. There are 4 things as I discussed, which we need to tell the ventilator to start, to set on a ventilator or to understand the ventilator mode. As I said, which were the 4 things? Trigger. Second is limit, inspiratory phase limit. Third is cycle. Fourth is the expiratory phase or the peak. So depending on these parameters, my whole asynchrony depends. So whenever you look at an asynchrony or you see your patient is not synchronizing well with the ventilator, the patient is discomfort and the graphs which are coming on the ventilator are not so easy or showing some haywire, try to look at each parameter one by one and you will be able to diagnose what is the dysynchrony that I am dealing with. Okay. So when I talk of dysynchrony, for the trigger dysynchrony, there is mistrigger, there is auto trigger, which are very easy to understand. There is trigger delay, again a little easier to understand. The one which are little difficult to understand are the double trigger and the reverse triggering, which I'll try to make it as simple as I can. Then there is flow asynchrony, which is kind of a limit. So when you're setting the flow, whether you have set enough flow, less flow or more flow will define your flow asynchrony. And your cycling asynchrony, which is early cycling or late cycling. So if you don't cycle as per the patient, you will again see a abnormality which is happening. Okay, and the PEEP, as I said, there is not much in the expiratory phase for us to think. Okay. Now if I look at this graph, okay, I can see there is this patient triggered here and there was a negative deflection and there was a breath which was delivered. The patient has tried to trigger at these points also, right, but no breath was delivered. So this is a missed trigger. Okay, it's written auto trigger, but it's a missed trigger. I'll show you all what auto trigger is. Auto trigger darling. Today I took a picture of an auto trigger from my eyes. Sorry. So here also we can see the missed trigger. I'll share the auto trigger on the WhatsApp group. Maybe Henna WhatsApp group. I'll send it to you. Okay. So this was a missed trigger where the patient has tried to attempt to trigger, but we did not trigger. Okay. So now why do missed triggers happen? If I ask. Now if you see that the patient is trying to trigger, but the ventilator is not delivering the breath, I have to correct the problem, right? That is why we are trying to understand asynchrony. If I am going to sedate the patient and give him the breaths that I want, eventually I am not achieving what I tried to achieve from this lecture. So when a patient has missed trigger, I have to first understand, am I giving him adequate trigger to trigger, or am I giving him a less sensitive trigger so that he has to put in more effort. So the trigger may be missed because of multiple factors, like maybe the patient has a poor muscle strength, like we see in a difficult weaning, a CINM, which is going to take its own time, but I have to give him a spontaneous breathing trial, so I may make the trigger more sensitive and do it. And more commonly, we may see these missed triggers in patients who generate a lot of auto PEEP. So when you have auto PEEP, the patient has to overcome the intrinsic PEEP and then the trigger that you have set to start telling the ventilator that you start delivering a breath. So the ventilator has to get a message at the ventilator end to tell him, boss, abhi you open the inspiratory valve so that the breath can be delivered. Okay, so if there is a lot of intrinsic PEEP which is there, the body or the muscles, inspiratory muscles have to first overcome that PEEP which is inside. Now to overcome that PEEP which is inside, either I measure the auto PEEP or do it, give that amount of PEEP to overcome the intrinsic PEEP, which is the formula is to give 60% of the intrinsic PEEP which is there, or you try to titrate your PEEP to look at the inspiratory effort that the patient is putting into. Okay, so when we put a patient on NIV, we often set our EPAP in a way so that we allow them to use less inspiratory muscles to begin the breath. Okay, so that trigger is easier. So if you have a COPD patient who doesn't have a complete relief from the bronchospasm and there is persistent auto PEEP even when you are trying to wean him, then in those cases, before you try to wean off the sedation, it is always beneficial to look at what is the level of auto PEEP and then give them the PEEP 60 to 70% of that auto PEEP so that the triggering or the weaning off is easier. Okay, nowadays we even have focus to look at the diaphragm contraction to decide how much PEEP to set and to wean these patients off. So this is the kind of auto PEEP structure which we see, wherein I have set a trigger threshold of the blue dotted line. So once the patient's inspiratory effort touches there, only then will the breath be delivered. If the inspiratory effort is less, that breath will not deliver. Or if I have made the blue line further away, it is going to be more and more difficult. Or if there is an auto PEEP, and the last graph that you see, the auto PEEP has raised the bar of the baseline up. It is not at 0. So even if the patient is triggering the amount that it's supposed to trigger, the -2 that I have said, it will still not touch my dotted baseline which is there. So for that I need to give him some amount of support in the form of an extrinsic PEEP to overcome that intrinsic PEEP. What is trigger delay? Trigger delay often happens in the previous ventilators or maybe more with the pressure trigger than with the flow trigger. So how a pressure trigger works is, it's basically a pressure which is generated at the lung end to tell the patient, ventilator at the ventilator end to open up the inspiratory valve to deliver the breath. So earlier when the older ventilators were there, they used to have a completely closed inspiratory valve. So there used to be some amount of lag which would happen in the opening of the inspiratory valve. But as the newer ventilators have come up, these ventilators keep the inspiratory valve slightly open, and there is some amount of bias flow which is running through the ventilators. So in that case, when the patient starts triggering, opening of the partially opened inspiratory valve is much easier, and especially with flow trigger, because the bias flow helps to communicate that flow difference very easily and faster, and the delay that is there is comparatively much lesser. So we hardly see this trigger delay these days in the newer ventilators. Okay. So a trigger delay, you may see that the patient started triggering much earlier, but actually the ventilator delivered the breath a little away from the. What is happening here? Has the patient tried to trigger here? On the upper, it is the pressure time scaler, middle one is the flow time scaler. But I can see a pink line which says that probably he has triggered. But has he really triggered? Okay, and then there are two consecutive triggers which are happening there. Can you see there? So there are two terminologies which we need to understand, the reverse triggering or the double triggering. Okay. So when a patient is trying to trigger a ventilator and he is spontaneously triggered, okay, and the patient now wants to continue the inspiration comparatively longer than what the ventilator wants to continue. So I have set the cycle of maybe 1:3. So then my inspiration stops at certain level, okay, because I set a respiratory rate of 10 with a 6-second cycle, and send the I ratio 1:3. So I have indirectly told the ventilator at 1.5 minutes you have to stop the 1.5 second you have to stop the ventilation or stop the inspiratory phase, and you have to cycle to the expiratory phase at 1.5 seconds, right? But the patient is not happy. He wants to continue inspiring. Okay, so I have prematurely cycled for the patient. But the patient wants to continue inspiring and he will contract the diaphragm again, that why are you stopping my inspiration? So in that case, I may see a double trigger. Okay, so if a patient is starting an inspiration on its own and wants to continue the inspiration beyond what you have given, you may sometimes see a double trigger. So this is called as a double trigger. But when you see a reverse trigger, in a reverse trigger what happens is the patient has not triggered the breath. It is a breath which came from the ventilator. There is absolutely no trigger when it started. Okay, but when it started inflating, the second graph that you can see, okay, here what happens is the ventilator increased its tidal volume, and when it increased its tidal volume, something stimulated on the diaphragm and the diaphragm suddenly contracted. And when it contracted, it tried to trigger the ventilator at that moment, and there was another inspiration which was delivered. So there was a reverse trigger. It reversely triggered something which was not supposed to be triggered. So what are the solutions on the two things? When there is a double trigger and the patient is trying to trigger more than what it is requiring, that means I have to increase my inspiratory phase of the cycle. But when there is a reverse triggering, probably my patient is awake prematurely, it is not trying yet to wean in because I am still continuing to give him full control breath. So probably deepening the sedation is what needs to be looked at. So then if there is a flow starvation, the inspiratory phase problem, that in that case the patient wants a higher flow than what the ventilator is giving. So I will see a concavity, like how we saw concavity in the COPD patient during the expiratory play form. Here I am seeing a concavity on the pressure time scaler, where I am trying to give a flow, but because the patient has a higher air hunger, it is still generating that negative pressure. So my pressure is actually trying to concave off. The pressure is actually which was supposed to go smooth up as positive, and because the patient is making a lot of effort to take that deep inspiration and because of its air hunger, I may see some scalloping which is happening on the pressure time scaler. Okay, and this scalloping tells me that the patient has air hunger or it is still is flow starved and needs a higher flow. And for a higher flow, this may often happen when we are trying to wean off our patients. So probably it needs a more pressure support, or maybe there is severe acidosis which is causing the patient to, have that air hunger. So we need to correct our factors why this whole thing is happening.
What is happening here? So this is the same thing which I told you all in double trigger. What was happening in double trigger? The patient took an inspiration, but it is not happy, doesn't want to complete the inspiration. But the ventilator I have set in such a way that it completed the inspiration, but the patient wants to continue inspiring. So I have prematurely cycled it, but in this case, the patient is not strong enough to trigger a complete breath. Okay, it has just given a small peak there. So the patient ventilator tries to do an expiration here. But the patient wants to continue inspiration, but the strength is not strong enough to continue that inspiration into a full breath or to trigger a full breath. So in that case, there will be a small notch which will be seen, and this is seen in premature cycling. So double trigger also is premature cycling, but because the strength was enough to trigger a complete breath, it becomes a flow double trigger, and because here it is not strong enough, this becomes a premature cycling kind of a asynchronous. And this is delayed cycling. So what happens is, here I am continuing inspiration, but the patient wants to now start expiration. So it is trying to throw out the breath, but my ventilator is still in the inspiratory phase. So because it is trying to throw out the breath against the inspiration which was smoothly going on, it shows as a peak in the end, which is a peaking at the end of the inspiratory phase, which is a delayed cycling. Okay, so if I decrease my inspiratory time or make my cycling earlier, there will be better synchrony. Sorry, reverse of the previous one. So that was premature cycling, this is delayed cycling. How it was very easy. Here there is a peaking at the end of inspiratory phase. There was no expiration has not started yet. Okay, the expiration, this is still inspiratory phase which is going on. The expiration is going to start here. The cycling is here, and but the patient has started expiring, and which is seen as a deflection, positive deflection on that, on my pressure time scaler. So there is, you can see there is absolutely no similarity. Here the problem is happening in the flow time scaler, where you can see a double notch. In reverse triggering, there is no spontaneous breath when you begin. When you begin a controlled breath, the diaphragm triggers at the end of the controlled breath. So reverse triggering and double triggering difference is that. Under double triggering, the patient is taking the first breath as well as second double triggered breath. There, in the reverse triggering, the first breath is a controlled breath, and because of the involuntary diaphragm contraction, which is not really spontaneous, but which appears to us as if the patient contracted. But this is because of the overinflation of the alveoli, which caused the diaphragm to contract. So maybe reducing my tidal volume so that the inflammation is not, the inflation does not trigger the diaphragm, or deepening the sedation will help. Because here I am still on the control mode. I don't want the patient to trigger. It was the involuntary unnecessary trigger which happened because of the over distension of the diaphragm. Any other questions?
Thank you, ma'am, for the wonderful session. I would like to request Dr. Sandeep Agarwal, sir, to felicitate Dr. Gunjan, ma'am. I would like to request Dr. Nikhil Varghese sir to felicitate chairpersons, Dr. Archana ma'am and Dr. Madhuri ma'am.
we will very soon be proceeding for the workstations. So there will be 4 workstations today. 2 will be for airway, right? So one would be for airway equipments, learn about airway equipments from your faculty. Second would be airway management. There we will show you the normal intubations, normal airway management, bag mask ventilation, normal intubation, LMA insertion, intubating LMAs, and front of neck access. So all of these are very, very important for your day-to-day routine practice as well as for your exams. So those who are going for exams, you have to understand that this airway is one of the most important section. You have to pass that independently, right? So try and clear all your doubts, try and understand the algorithms and what needs to be done in the difficult airway scenarios. Second 2 sections are on HFNC and NIV, which are there, and 1 section will be on obstructive airway diseases, which I had told you about so many things. So all those things you can see on the real life scenarios, and we will show you the graphs on the ventilator and what to do with the difficult scenarios, right? So all of you have been given different colored these bands, right? So the batches will be based on these color bands. So red ones will be in one batch, green and blue will be on one batch, and one is white, I guess, right? So those will be batches. All the people who have red bands can come on this station 1. Those with green will go to the station 2. Those with blue will come here, and white will, I will ask you when to come, just it. And the white ones will go there and then rotate clockwise. So every station will be around 30-40 minutes. I would again tell you to clear your doubts as far as possible, right? So give us 5 minutes to arrange everything, and then we will call you.
Stop now. जरूरत नहीं, वैसे दिखाने होंगे ना, कोई टेबल करेगा जरूरत नहीं हो रहा उसको। वही करना था।
नाही काय स्क्रीनवरती काही दिसणार नाही, स्क्रीनवरती काही दिसणार नाही. रेकॉर्डिंग तोपर्यंत सेकंडसाठी ऑफ कर. आपलं इथूनच घ्यायचं.
स्क्रीन पे कुछ नहीं है, जो भी है ये इधर ही है. अच्छा, ये कुछ है क्या? हाँ, टाइम लगा, अभी नहीं आया. मेरे को वैसे कैमरा लेने का ही होगा, कैमरा लेने का ही होगा.
ले ना.
पुढे गेलं का जास्त? कॅमेरा पुढे गेला.
पुढे गेलं पुढे नाही रे,
पुढे गेली.
मी तेच सेटिंग केले. हां, म्हणून तर ते खालीवर पहिल्या किती व्हायचं, आता बघ कमी झालं. स्क्रीन पे वो वापस केबल कौन डालेगा? केबल कौन डालेगा?
केबल ऑलरेडी लगा है ना.
नहीं, उसने नहीं ली.
चार ग्रुप होतील, दोन ग्रुपचे जातील, दोन ग्रुप ते रोटेट होते. तर तुमच्याकडे दोन कॅमेरे आहेत की नाही? हो. तर पहिल्या सेशनचे दोन कॅमेरे होते आणि नंतरच्या फक्त दोन चार आहेत.
वरतून करायचं
सेम त्यांना ते चार वेगवेगळे स्टेशन्स आहेत ना. एका विद्यार्थ्याला इथं पण जायचं, तिथं पण जायचं, तिथं पण जायचं, तिथं पण जायचं, असं चारही पण. म्हणजे एकाच ठिकाणी वेगळ्या ग्रुपमध्ये चार टीम येणार. पहिली टीम येईल, मग ती तिथं जाईल, तिथं जाईल, तिथं जाईल, असं सेम टाईम. सेम टाईम आपण काय करतो, कॅमेरा दोन्ही चालू, दोन सर्कल झाले की मग परत सर्कल असं होतं. असं पण आपल्याकडे वायरलेस पण आहे. ते तेवढंच स्टेशन तेवढं लोकांसाठी
मंडेला सांगू. हो चालेल. स्टुडंटनी कमी झालं, 2-3 ते घरी गेले सेप्सिस 126 तो काहीतरी ते तिथे ते रिया आहे का आपलं निरामाचे ओल्ड एज सेंटर. हां निरामय ते पण त्याचं काहीतरी इफेक्टिव्ह झालं क्लिअर झालं. मी मंडेला सांगतो. मॅडम आहे पॉझिटिव्ह बघू हां तीच मॅडम मग ते थोडे एज दिले मग ते कसं
नहीं बोल रहे हैं सर, नहीं सर बोल दिया उधर से करो, इधर से करो। ये फ्रेम
So all the red ones on table 1, airway equipments. Red ones, airway equipments. Green on airway management. Achha, yellow is red. Okay, yellow. Green on NIV and HFNC. Green on NIV, HFNC. And white or yellow on obstructive airway diseases. White, yellow. Okay. Red, green, blue. Blue ones here, obstructive airway diseases.
थोड़ा अवॉइड कर लेने के लिए फेस चेहरा हाइट चलते देखिए ये फ्रेम पकड़े लेंगे.
All the delegates and attendees, please also remember you have to sign again tomorrow on the attendance sheet for MMC purposes.
हाँ कौन रुक ना जरा सब्र करो
हाँ हाँ मोस्ट ऑफ जाते हैं क्वेश्चन आन्सर वगैरह होते तुम्हाला मी पाठवलं PDF
हाँ ते बघितले
त्यामध्येच टायमिंग आहे
कन्फ्यूज होतं देखा है मैंने लोग देखा मैंने उसके सूर्य का सामने अपोजिट में ना कोने में एसके कॉलेज के सब लोग वैसे रास्ता था बताओ एसके कॉलेज के सामने जो था कंपाउंड था उसके बाजू में पहले दुकान था ना वही ना देखा मैंने हाँ देखा बाजू देखा मैंने सोचता हूँ मैं चेंबूर में देखा इनका स्टूडियो था बोलते स्टूडियो में यही कुछ है क्या स्टूडियो में हाँ स्टूडियो में कौन पैसा नहीं सभी नंबर मंगाओ ना सभी नंबर चाहिए हाँ सभी
सरांना सगळी माहिती सविस्तर द्यायला सांगा जे तुम्ही माझ्या फोनवरून पुन्हा व्हॉट्सअप कॉल जाईल किंवा नॉर्मल कॉल जाईल बोल की काय नाही नाही ते त्यांना सांगून ठेवा सर त्या टायमाला साहेबला बोलत बसलं असेल ना ते फोन करतील आणि ते फोन बोला तसं मी जायच्या टायमाला ना तुला सांगितलं आज चालू आहे सर तिथे त्या टायमाला त्यांना शिकवलं असं आणि त्यांना ऑनलाईन शॉर्टकट त्यांना सगळं सांगायचं ठीक आहे हां चालेल
मेरे पास में एक बंदा है जिन्होंने अपना फोन पे साइड था हेलो जैसे बात करूँ साथ में बात करो ना उनसे वो सर्वे नंबर कुछ तो चाहिए उनको फिर वो देखने के लिए आएंगे चलेगा सर हाँ मेरे पास में चाहिए हाँ ठीक है बात करो
नमस्कार मला कुठं भेटण्यासाठी पाहिजे सर म्हणजे तुझ्या कुठला चेहरा वगैरे नाही आपण येणे आहे का रोहिंदरमध्ये स्वतःची आतून लाईट लावली म्हणजे लाईट ठीक आहे ना साधारण सर्व पाठवा हां ठीक आहे हां ठीक आहे का बोलू ना
फोन नंबर का पे दीजिए मुझे चलिए कोई चला ओवरटेक ना कर ओवरटेक ना करना सभी नंबर आपको उससे कॉन्टैक्ट करो मिलता नहीं ना मेरे को गाड़ी कॉन्टैक्ट आप उससे जब कोई प्रॉब्लम तो नहीं
हाँ बस उसकी अभी
नहीं वो तो ना आखिर नंबर साथ में आजू बाजू में तो बात ठीक
चाय थोड़ी भात चाय बस
चालू की तरह नहीं है ब्रेक ब्रेक बोलेंगे ना लोग
बोला नहीं करता
अभी क्या कर रहे हैं आगे आगे से ऊपर से निकलना चाहिए
45 मिनट अभी चलेगा
ये रुपये ना स्पीड चलेगा आज मुझे पता उसका फोटो बहुत खराब हुआ है उसका फोटो बहुत फोकस नहीं हो रहा है एलईडी का ब्राइटनेस बहुत ज़्यादा है ना तो इनको आगे लेके आके
डायरेक्ट बाउंस मारने का था ना
कौन से मारा मैंने बाउंस आ रही नहीं है कौन से बाउंस नहीं मारना ठीक ये सब ऊपर से ये बाउंस से मारा
ये नहीं तो मतलब राइट आ गया
एलईडी का बोल रहा हूँ ना बाउंस में मारा तो डायरेक्ट मारता तो नहीं आता था बाउंस में आया फोकसिंग से ऑनलाइन करता ये ऐसे
स्ट्रॅटेजीज केली आणि त्याच्यातून फोकस इम्पॉर्टंट अमेरिकन लोग एजुकेशन आपको ऐसा चलेगा भी नहीं लेवल ही अभी लेवल
LED है ये सोनी केस में वो ये रहता है वो
नागेश त्याला धागा बांधला होता माझ्या वरती हँडलला कुठे गेला तो लाल कलरचा धागा बांधला होता त्या हँडलला
करता होता का
हे घर
पहले चलू
क्रिया चालू आहे क्रिया चालू आहे चालू चालू झालं तिथं आता तिकडे झाला वाशिंग झाला शिवाय आता आपल्याकडे व्हावं लागेल विचार करतो का सपाट जाऊ दे तिथे पूर्ण होता कधी पाण्याची टंचाई सगळं मंत्र्यांनी सगळंच कसं भेटतं ते कधी मरत नाही तुला मुलं किंवा याच्यामुळे अटकले होते काय आपण तरी कंची यायच्या तिथं काहीच नाही होईल आता आता बारामती बघितलं तरी शरद पवार तर काही घराला काही नाही धक्का लागला बाकीचं बोलतात पैसा काय घर असतो भरलेलं असं मोठं भरल्याबरोबर करंजाला कोणी मर्डर केली काय नाही भावाने भावाचं मर्डर केलं सगळ्यांपेक्षा सर्वात लागली गाड्यामध्ये समजते मुंबईचा नाही दिसला त्यालाच वेगळे असतील ना ठीक है सर बोलो हेलो हेलो हाँ साहेब बोला ना जय मी खारघरला साहेब खारघरला आहे तुम्ही कुठे चेंबूर कसं सोडणार तुम्ही असं तुमच्या लोकांना सोडणार का नाही नाही खारघरला बोला ना सर नाही ना चेंबूर नाही सोडणार चेंबूर सोडून कसं झालं मायभूमी आपली मी तुम्हाला मग करणार होतो माझी ट्रीप पण ऐका ना ते वाशी आणि खारघरमध्ये आवाज सुटते काय बरं थांबा एक 10 मिनटं 10-15 मिनटं मला करतो बाहेर येऊन हां सर
Okay, request all to please switch on to the next table.
दिलं ना कार दिलं ना हां सर ठीक आहे
जेवणच आहे एक पण कुठं बी जेवणच आहे आलू हमें जरा कुछ चेंज हो तो फोटो निकाले इसका सब निकाल दिया मैंने तो मिस कॉल मांगना वो नंबर बोला आपको 967 व्हाट्सएप पे देना
आहे क्या व्हॉट्सअपवर नंबर होत नाही अरे ते नंबर पण येत नाही व्हॉट्सअपवर काय नंबर टाईप करा येत का नाही ट्रिपल वाई होईल आता तो नंबर घेतला सेव करावे जो ऐकत नाही एकशे 23 आणि आता ते नाही ना चालू व्हॉट्सअप ठीक आहे फोन मी त्याला येऊ का बाहेर काय करता चालू आहे प्रोग्राम फोन करेन मी आता बघा कधी काय मध्ये ये चाय उकाळला की ना चाय उकाळला की ना चाय पत्ती आता गेली बुटक्या नाही बुटकी तुला गवतीच्या पाहिजे अद्रक पाहिजे सांगायला लागतं अगोदर
Request you to please switch to the next station.
विकास मेरा फोन करो बोलो अच्छा तो व्हाट्सअप दिसत का नाही व्हाट्सअप दिख रहा है शो ही नहीं हो रहा
नंबर मतलब नहीं वो टू कभी कभी दिखा था 2 मिनट में भेजता हूँ मैं तुमको भेजा ये फोटो निकल के आता चलो नंबर भेज दिया मेरे को उसने उसको फोन था उसको क्या बोला मालूम नहीं वो अपना कम करेगा
मतलब अभी इतना ज़्यादा बोले कितना कम करेगा
रेट चालू है
रेट है
मेन रोड पे टोल के बाद नहीं है मैं पैसा 2 मिनट फोटो निकल जाता हूँ
फोन है अभी फोन नहीं ठेवलं म्हणजे आपण फोन ठेवलं चार्जिंग केस सेम है आपका नेट में इसलिए दिखा रहा नहीं है बेटर ऑफर दे देर ऑफर देता हूँ तो देता हूँ ऑफर पैसों से पैसा क्या होता है मेरे कॉलेज के हिसाब से और आता रहेगा मैं एनुअल डिस्ट्रिक्ट का काम लेता हूँ मैं वेटिंग करना बहुत कम वेटिंग कर ऐसा नहीं किया उनसे दुनिया में वेटिंग कर एक गुजर में टाइम गुजर करने गुजर एक गुजर किसको नहीं पता एक गुजर के लिए भी जब बच्चन के लिए रोज ढेर सारा काम रखेंगे इसलिए लोग का काम नहीं है उसका पार्ट में ना हो गया ऐसा दिया नहीं उस टाइम रेट कम था उसका रीज़न वही ना कभी रेट नहीं नुकसान तो मांगा भी नहीं सबको दिया भी कुछ सुना मैं सामने से फोन किया उससे उसी में सब आगे कुछ नहीं पैसा भेज दिया उसने पैसे कम किया मुस्लिम अच्छा पढ़ा लिखा बन गया मुस्लिम बेसिक से सीखा ओपन माइंडेड है वो लोग मैं बोलता रहा हूँ मैं दिखा दूँगा मैं दिखा तो खुद बोले मेरे को बोलेगा ऐसा मुझसे कम नहीं होता थोड़ा सा कट्टर बनती पढ़ लिखा है लोग उसकी कजिन मेरी क्लास में गया उसके सगे भाई का क्या था मैंने नेटवर्क में तो इसके लिए होगा नंबर ये भी जब बार बार एक वही जमीन दिख रहा ना बार इसके लिए होता है 2 बार उसको भेजा एक आदमी तो वही जमीन दिख रही ये दिखा क्या मतलब एक ही जमीन को जो है ना सभी नंबर ये है आडियो है ना आडियो भी तो नहीं हो चुका पूरा रखना उस नाम में आता रहेगा
किचन बहुत अच्छा काम पब्लिक कितना रोता ना, लाइन कितनी वाट लगा के रखी है ना, लाइन तो वाट लगा के रखी है, लेकिन हम क्या करना है, कुछ एक्सक्लूसिव क्लाइंट पकड़ना, अपन भी एक्सक्लूसिव क्लाइंट ही पकड़ना, रेट ठोक देने का, बहुत रेट ठोक देने का, बोलेगा ना बार्गिंग करना स्टार्ट करेगा ना, बोला भाई बार्गिंग करना है तो फिर सीधा ऐसे बोल देगा ना, तो सीधा इंसल्टिंग के लिए तो उसको करने के लिए आने वाला है, मालूम की नॉलेज नहीं है कौन सा कैमरा क्या है, नहीं अभी तो सब भैया लोग ने सब मार्ट लगा के हाँ बराबर ये तो मेरा तो 20,000 पगार में काम करते 15 लाख रुपये कैमरा लेकर के काम करते आता कुछ नहीं आता कुछ बी एम बच्चों ने पापा घर में बोलते हैं मुझे कैमरा रखिए और वही फिर फ्रेंड सर्कल में जाते हैं, मैं तेरा करता हूँ मैं तेरा करता हूँ मैं तेरा करता हूँ, बाद में एक्चुअली फिल्म करेंगे पास बड़ा मालूम पड़ेगा रोड साल आपने घाट पैसा बचाएंगे, बाद में थोड़ी के भागेंगे दूसरे बिल्डिंग जाएंगे अपना तब तो अपनी मेरी बात ना करिए ना, वैसे वही चालू है ना क्योंकि अभी बच्चा तो कॉलेज पढ़े जा रहा है, मैं मेरे बच्चों की लाइन कभी नहीं डालूंगा, कोई नहीं डालेगा, कोई नहीं डालेगा, बोले भाई तो पढ़ ली लैंग्वेज तो कॉमर्स का एमबीए का यही पैसा नहीं, लेकिन आपको एक बात बोलूँगा, मेरा फ्रेंड मेरा असिस्टेंट था इतना मेरा थोड़ा बहुत काम पे रिश्ता नहीं रहा, तो उसका वो तो बोले मेरे अपनी बेटी को वही बनाएगा सबसे कंप्लीट हो गया ना उसको, अभी मैं कॉलेज में अंबानी का जितना फोटो देखते ना, अंबानी का फोटो जितना मीडिया के ऊपर, तो मेरा दोस्त की भी करते हैं ये टचिंग करते तो बोले ना काम बोलेगा ना कोई हर सब देगा भी नहीं कोई काम नहीं, अपना खास है उधर से वो बड़ा फोटोग्राफर है ना वो, वैसे स्टार्टिंग में तो कर सकता ना कोई साथ में लेके जाएगा तो ना, और काफ़ी चीज़ हाँ वैसे कुछ नहीं, लेकिन वो तो चलो तुम्हारा भी ये हो गया उनको ऐसे कुछ शुरू करना पड़ेगा, अच्छा आपको भी नहीं अच्छा लगेगा, कुछ नहीं पैसा मिलाना पड़ेगा, मेरा दोस्त था पिक्चर में काम करने का, मूवीज़ में कैरी कैमरा ऑपरेट कर कैरी कैमरा कैसे कैमरा मैन का हो, उसने काम भी नहीं लगा कुछ, तभी मैं आया इधर, मैं मेरा कॉलेज गया 3 साल एग्ज़ाम देके आने का, क्लास जाने का, बस टाइम पास करने का पूरा, उस टाइम पे आज से 15 साल पहले 2,000 रुपये मिलने का पर डे का, और बाहर घूमना अलग से इतना पासपोर्ट था उसका मैं फिर पाकिस्तान बांग्लादेश हुआ था ना, ये सब कंट्री आता ना आतंकवादी लोग कंट्री, वो कंट्री छोड़ के हर एक कंट्री घुमा है, पढ़ने लिखने को आता भी नहीं, ही था कैमरे का, टेरी ने बंद कर दिया ना, नया निकला गेम उस टाइम इंडस्ट्री में 4-5 रोज नहीं मिला मुझे। फिर इसका बॉस ने कैमरा 5 कैमरा था उसके पास में, उसको काम से निकाल दिया, एक ही कैमरा लिया उसने। तो ये रोड घर पर दूसरा घर पर बैठा था, लोगों ने पाला, उसने मेरी पगार 12,000 पगार दी मेरी, मेरे दोस्त ने पाला 2 साल तक। उसने मेरे दोस्त को बोला भाई ऐसा है, इन्वेस्ट करेगा तो बता।
हेलो कामल नहीं यार तबीयत बड़ी है ना, तबीयत बड़ी है ना, कर ना आराम से, कशाला बाहेर पडला नाही। त्यांनी मला 2-3 वेळेस फोन केला ना, कुठे कुठे त्याचा फोन उचलच नाही तुझा, म्हणून तुझा फोन आता कट केला, मला वाटतं तू करते काय म्हणून कट केला फोन। काल बघितलं 200 वेळा कापलं मला। ठीक आहे मी बोलतो ऐका ना, ते वाशीचे डेव्हलपमेंट जागा बघा, ते तुमच्या गाडीच्या खाली आहेत ना जसे गाळे मोठे मोठे, तसा गाळा पाहिजे विकत, डायरेक्ट पार्टी आपल्याकडे, डायरेक्ट पार्टी लोक पळवा जरा डोकं जरा फास्ट काय असेल तर सोर्स लावा, हां टाकतो डोकं लावा आपल्याला डायरेक्ट पार्टी दुसरी वेगळी नाही पाहिजे, हां हां चालेल।
कल मेन रोड वैसे कुछ चाहिए ना,
नहीं लोकेशन प्लानिंग चाहिए, अच्छा रहेगा तो और अच्छा रहेगा, उधर नहीं चलेगा।
ऑफिस बहुत है लेकिन
नहीं उधर नहीं चलेगा, उधर उसका
पूरा बिल्डिंग है 3 मंजिला
तो आगे
We request to switch on to the next station.
ये सब टेस्टिंग है ना, वही बात अंबानी का जो भी फुट आप देखोगे ना, ज़्यादा नहीं
तो और करता रहेगा और
सीधी से बॉस करते हैं। हाँ ये बड़ा बड़ा सीधी ये जो फोटो दिख रहे हैं इसमें भी चेंज किए, सलमान का तो बहुत, सलमान का फिफ्थ में गंदा उसको भी टाइम लगता है
दूसरा अच्छा ये हो गया ना, उसको भी सॉफ्टवेयर में लगा सॉफ्टवेयर बेसिस में,
तो इसका एप्पल का तो इसका ये इसका
सॉफ्टवेयर कौन सा
बदला तो उसमें
चाय चाय बनाना पड़ता है।
तयार कैसा फील ये नागेश चाय रेडी जा ना किती जा तू जा मी पटकन कसा हे बघ
सुनील भी नया कैमरा आएगा नहीं ऐसा वाले में वही सुनना तो चेंबूर जाने वाला है
निकाला था, कल बाजू का वो भी निकाल देना, नाव देना एक ही साइड।
तुझा आवाज नाही तुझा आवाज येत नाही. मी तुला नंतर कॉल करतो. मी तुला थोड्या वेळाने कॉल करतो. मी तुला थोड्या वेळाने कॉल करतो. दादरला गेली का तू?
रेंट भी कम यहाँ पे टमाटर के पास 16,000
कामोटा मी थांब होता हॉटेल उधर 9,500 भाड़ा में 4 साल पहले बसा था 5 साल पहले कोरोना में
15,000 14,000 साल में
तो है 8 साल पड़ेगा 10 टका फास्टली ग्रो होता है बड़ा भाड़ा में. मेरे साथ ये कभी छुट्टी होगा हम वहाँ
लगने के टाइम में 12 एक ही बजे
तो हमको आदत पड़ गया ना बाबू.
आदत लगा फोटोग्राफर और वीडियोग्राफर आता है सबसे फर्स्ट और जाता है सबसे लास्ट. ये ध्यान में रखना.
भाई शादी का सीजन में बहुत दिन होता है ये सभी परवड़ता है
मिलने को मिलता है तो बाबा शादी का तो बिल्कुल नहीं सब आता है
11 बजे तक के लिए आपने से मतलब नहीं हो काम में
ये पैसे ये ऑर्डर दिया पहले भाई सीधा 60-70% एडवांस ये
सही आपने फोटो पण स्वतःची वाट लावली पूर्ण 90% पैसे दे म्हणून विषय संपला
नाही आलं ना ऑर्डर आता तुझं मी काय तुझा ब्रेक आहे 3.5 पूर्ण पार्टी ब्रेकअप आपने कोई हेल्प की थोड़ा सा कम रेट में
वही जो बात है ना गरीब अपनी वो बात अगर अपन कट करेंगे ना तो
हाँ बहुत प्रॉब्लम सॉल्व हो जाएगी.
पहली रेट बढ़ा के बोलने कम करते हैं ऐसे ज़्यादा मैंने वीडियो में मैसेज सीधा बोला 8,000 रुपये से जाएगा कम करते 500 कर देते भाई उसमें रेटिंग वाले को भी दे देंगे एडिटिंग तो फिर बाद में भी नहीं पड़ और एडिटिंग ये कुछ घंटे का घंटे 4.5 नहीं पड़ रहा 1500 इसको दिया 3,000 मिला 2 घंटे का
मैं एक पार्टी ठीक है मैं शॉप वीडियो भी है आपको
कितना पैसा
वो भी गाना बिना बोलेगा
जैसे रिकॉर्डिंग करेंगे
कहीं शादी होता है मेरे को पूरा का पूरा पैसा कितना मैं उसको 120 रेट बता उसके ऊपर 1,000 रुपये ज़्यादा बता 7,000 रुपये तक मिले 8,000 रुपये मिले फोटो का पैसा बोल रहे हैं आप
4 साल चल जाते हैं.
हाँ नहीं कम तुम्ही एग्जाम्पल दिली म्हणजे 2 महिन्यात 50% जी तुम ॲडव्हान्स
मैं पहले एडवांस दे लेता था और जो पार्टी जनरल में उसका ही काम वो गरीबों का काम नहीं. अभी यही काम करना पड़ेगा. मैं एक्सप्लेन करके फल तुमको देगा बाकी ये परवडते ॲक्च्युली पैसे रोकणे आपल्याकडे आहेत. तुमको लेने का ऐसा नहीं करना है. कितना एडवांस चाहिए तो काम देगा नहीं उसमें क्या बोलते हैं पार्टी बहुत नहीं ज़्यादा बेटा छोड़ देने का
प्रॉब्लम वो समय में ना वो समय में अपना पैसा अपना पड़ेगा पैसा कैटर को जैसे हालत है काम
लेता है पहले लास्ट में कुछ लगे पैसा लेता है एग्जाम्पल अपने में पॉइंट ढूंढते हुए कितनी बार इसको पैसे कम कर सकता है. 5,000 अपना प्रॉफिट लास्ट में वीडियो देने का ही फोटो भेज देने का शॉर्ट करके दूँगा तो बाकी आप पेमेंट कर दो उनको वीडियो मैंने बोला ना 10 का 9 10 का 7-8 हज़ार एक्स्ट्रा नहीं और दिया भी बाकी नहीं किया. बेकार है लेकिन उनको इंटरेस्ट नहीं मिलता वो लेके जाने के इंटरेस्ट नहीं देता खाली वो दिखाओ करके उसको वहाँ पर. लेकिन उसके धर्म में क्या होता है इसीलिए क्या करते हैं निकलते हैं लेकिन लेते नहीं देते. बहुत सारे लोगों के साथ ऐसे की निकलते लेकिन लेके नहीं जाते पैसा ले. और अपनी क्या होता है आदमी लेके जाएगी ना मेरे पास तो पड़ा है लेकिन उससे मतलब ही नहीं पड़ा मेरे वास्ते रखते रहे.
वो एक टेस्ट टिप जरूर करो
काय चाललं कॅमेरा हलते इथे किती असते
9 क्रिया
आज किती आले 8 वाजता 7ला आले.
अरे आज वायरिंग करेक्ट वायरिंग एक टाकायचं
5:30चा आराम लावलं बाबा माझे जवळ पाऊस इतका आलं पाहिजे घराने बाहेर मला पहिला पण लागलं ना तेव्हा घरात मला खाली पाऊस पडत होता पाऊस सामान्य कसं
बाद में आके
पहले आपण ना
अभी हम लोग होने वाला है सबको बुलाएगा जब लोग बुलाएगा ना पूजा भी रखेंगे तब सबको बुलाएगा आ जाओ जब अगर लगे गेली तर खाली पडतो मला माहिती नाही.
इस
we conclude today's session here, and thank you for all your active participation. We will continue with day 2 workshop tomorrow by 9 a.m. So request you to be present tomorrow by 9 a.m. Thank you.